Hello, friends. Welcome to this session of ENT clinical questions. The kind of questions which we are getting nowadays in the exam is more, clinical, more situation based, and they ask you some relevant part of the, management or diagnosis or investigation, or maybe clinical anatomy, or maybe some applied aspect in integration with some other subject of basic or paraclinical sciences actually. So that's how this test has been designed. And let's do one by one every question. The first question is, a young lady with follicular carcinoma of thyroid gland has underwent total thyroidectomy. While surgery, both of her recurrent laryngeal nerve got damaged. Which of the following will be the procedure needed in the case? Type 1 thyroplasty, type 2 thyroplasty, type 3 thyroplasty, or type 4 thyroplasty. Now, what has happened in this case? As you know, thyroid surgery has got a known complication. It can lead to the paralysis of recurrent laryngeal nerve or superior laryngeal nerve. Now, if you remember that the thyroid gland at the upper pole has got the superior laryngeal nerve, and at the lower pole it has got the recurrent laryngeal nerve. So what the question is saying is that the recurrent laryngeal nerve has got damage on both sides. Okay. Now, do you remember the famous statement of anatomy? All muscles of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Okay. Now, if both R, L, N are gone, now you can understand that only cricothyroid muscle is working, because we remember the statement that all muscles of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. In this case, both recurrent laryngeal nerve have been damaged by the surgeon during total thyroidectomy, which has been done for a malignancy of the thyroid. Now, if you remember, cricothyroid has got actually two functions. One is that it is adductor. Adductor means that it closes it. And number two is it is a tensor. Tensor. Tensor means it tenses vocal cord and it actually gives you quality of the voice. Quality of the voice. Okay. Now here, this is more important to be considered. Only one muscle is left, cricothyroid, and unfortunately that muscle is also adductor. Adductor matlab close. It will close the vocal cord. Okay. Now what will it lead to? That due to adductor property, vocal cord will come in midline, permanently in midline position. Vocal cord come in midline position. And this is called as bilateral abductor palsy. This is called as bilateral abductor palsy. Am I clear? This is called as bilateral abductor palsy. Okay. Now this is a very serious situation because both vocal cord are in midline. They are paralyzed, but unfortunately they're lying in the midline. It's closed position. And there is a fundamental rule to remember for vocal cord is that we breathe with open vocal cord, but we speak with closed vocal cord. These are permanently closed vocal cord. So the problem will be respiratory difficulty. There may be stridor, but voice is normal. I repeat, vocal cord in midline, and the rule is we breathe with open vocal cord, we speak with closed vocal cord. So in this case, you have to remember vocal cord are permanently closed, per midline, permanently closed vocal cord. Okay. So what will be the symptomatology of this patient? That's also another MCQ beta. The main thing will be respiratory distress. It's a very serious emergency. Plus stridor. Whenever the air passage gets narrow, there is a sound called stridor beta. But very important thing is voice is normal. So this is another question, that what will be the symptoms of the patient when both recurrent laryngeal nerve have been damaged during surgery of thyroid. So patient will be post-operatively having respiratory difficulty and stridor, but voice will be normal. Now this is an airway emergency. Okay. So if they ask you next question, immediate treatment of this patient. Immediate treatment of this patient would be certainly what? Tracheostomy. So they will ask you, what is the immediate treatment with this patient require? Means that this patient who has suffered from bilateral recurrent laryngeal nerve paralysis, what would be the immediate treatment needed for that patient? It's an airway emergency, so immediate treatment will be tracheostomy. Okay. After tracheostomy, you have saved the patient. Now wait for 6 months for any spontaneous recovery of the vocal cord movement. But if after 6 months there is no movement, coming back, then we say definitive treatment or treatment of choice, which is offered later on. Immediate treatment is to save the patient. Treatment of choice is lateralization of vocal cord. Okay. So after immediate treatment, what we do is we give actually the treatment of choice or a definitive treatment, which is given after a few months, which is 6 months. Okay. And the treatment of choice or definitive treatment will be type 2 thyroplasty. You know, type 2 thyroplasty. Type 2 thyroplasty is lateralization of vocal cord. Lateralization of vocal cord, because the vocal cord have come in which position? Midline position. Both are close, midline position. So in this case, you need to do lateralization of vocal cord, and that lateralization is also called as type 2 thyroplasty. Type 2 thyroplasty. Am I clear, beta? Guys, come back over here. Now please read the question. What is saying that both recurrent laryngeal nerve have got damage during thyroid surgery. Okay. Okay. What would be the procedure needed in this case in future? Immediate treatment is tracheostomy. But in future, after a few months, the patient would be going for type 2 thyroplasty. And type 2 thyroplasty is equal to lateralization of vocal cord. Lateralization of vocal. Type 2 thyroplasty is lateralization of vocal cord. Beta. Okay. Okay, which is lateralization of vocal cord. Okay. Now let's revise once again this other thing also. Type 1 thyroplasty is medialization of vocal cord. Medialization of vocal cord. And this is done for adductor palsy. This is done for adductor palsy. Am I clear, beta? Now, type 3 thyroplasty is shortening or loosening of vocal cord. And this is done for puberphonia. This is done for puberphonia. You know, puberphonia means male having female kind of voice. And type 4 thyroplasty is lengthening or tightening of vocal cord. It is done for androphonia. Am I clear, beta? It is done for androphonia. Okay, bache. Once again, beta, let's revise all types of thyroplasties. Type 1 thyroplasty is medialization of vocal cord, and it is done for, let me write it down for you. Type 1 thyroplasty is medialization of vocal cord, and it is done for adductor palsy. Okay, but type 2 thyroplasty is lateralization of vocal cord. It is done for abductor palsy. Am I clear, beta? Now, again, type 3. Type 3 is shortening or loosening of vocal cord. It is done for puberphonia. Okay. And lastly, type 4 thyroplasty. It is lengthening or tightening of vocal cord. It is done for androphonia. It is done for androphonia. Am I clear, beta? So these are different type thyroplasty, and these are 8 MCQs, beta. So these are various type of what? Thyroplasty. Type 1 and type 2 are opposite of each other. Type 3 and type 4 are opposite of each other. Did you notice that, beta? Type 1 is medialization, type 2 is lateralization. Type 1 is done for adductor palsy, type 2 is done for abductor palsy. Type 3 is shortening, loosening of vocal cord, type 4 is lengthening, tightening of vocal cord. Type 3 is done for puberphonia, and type 4 done for androphonia. So this is high yield slide, beta. These are 8 MCQs actually right now. Am I clear, beta? Fine. Cha. Now everyone, let's come to the next question, beta. Question number 2. Now, The CT scan of the neck of the patient of carcinoma larynx has been found to have the involvement of epiglottis, right epiglottic fold, right true vocal cord with fixed right true vocal cord. Fixed, please see, with fixed right true vocal cord. Beta. Can you see that? Fixed right true vocal cord. Beta. Am I clear, beta? Now this is T3, beta. Now this is T3. This is T3. If you remember the laryngeal cancer staging, fixed vocal cord is T3. Fixed vocal cord is T3 beta. And you know the treatment of T3 and T4 is total laryngectomy and radiotherapy. The treatment of T3 is total laryngectomy and radiotherapy. Is that clear to all? Let's revise the various stagings of the laryngeal cancer beta. Okay, now let me go through. So the answer to this question is, of course, total laryngectomy and radiotherapy. Why? Fixed vocal cord means T3 beta. But what is other stages beta? Let's revise the main thing beta. Now T1 means when only one structure involved. Okay beta. This is just a simplified thing beta. T1 is only one structure involved. T2 is more than one structure involved. More than, for example, tumor involving epiglottis and epiglottic fold. Two structure, T2. Okay. But T3, your MCQ beta, very common question, T3. T3 is vocal cord is fixed or immobile. Okay. Vocal cord is fixed or immobile. And lastly, T4, thyroid cartilage is invaded. T4 is thyroid cartilage is invaded. There is invasion of thyroid cartilage. If the MCQ says vocal cord is fixed, it should be T3. If the MCQ says thyroid cartilage is invaded, the cancer has invaded thyroid cartilage, T4. Very simple thing to remember. If vocal cord fixed word is written or vocal cord immobile word is written, it is T3 beta. But if it says something about the invasion of thyroid cartilage, think of T4 beta. Okay, think of T4. And for your kind information, treatment is for T1, T2, mainly radiotherapy. And for T3, T4, for these two, total laryngectomy followed by radiotherapy. I repeat, beta, for T1, T2, radiotherapy, T3, T4, total laryngectomy followed by radiotherapy. Am I clear? Once again, beta, T1 means only one structure involved. T2 means more than one structure involved. T3 means vocal cord is fixed or immobile. T4 means thyroid cartilage is invaded. Okay. Now T1 and T2 treatment is radiotherapy. T3 and T4, the total laryngectomy followed by radiotherapy. Now look at the question once again, but this is the type of question which scares you in the paper. It's such a long question. But you know what the keyword is? Don't forget the keyword. Right true vocal cord is fixed. Can you see the fixed word, beta? Can you see the fixed word here? Fixed. Can you see the fixed vocal cord? Fixed. Now this is the keyword. In MCQ, clinical scenario based question, always read the choices, then see the statement, and then look for any key thing which you know surely that this keyword is particularly linked with T3. Then forget about the other thing, beta. Then forget about the other. Don't keep on dissecting the rest of question. You have only 1 minute to solve the question. Focus on that beta. Okay. So this is a T3 tumor. So the answer is total laryngectomy plus radiotherapy beta. Am I clear beta? Fine. Okay. Now next question beta. Next question is third question beta. Everybody, third question. Which structure is not removed in radical neck dissection, R&D? Radical neck dissection, R&D. Guys, please understand, this is the surgery which is done for metastatic cervical lymphadenopathy. Metastatic cervical lymphadenopathy matlab secondary neck node beta. Secondary neck node. Secondary neck node beta. I'm a clear beta. Secondary neck node. Guys, in any primary of the head and neck, there are many head and neck cancers. We have oral cavity cancer, oropharyngeal cancer, laryngeal cancer. There are many cancers of head and neck, and all these cancer will eventually drain into the draining lymph nodes of these areas. So in any surgery of head and neck tumor, you remove the primary. Along with that, you have to see If there is a neck node secondary also present in that case, which is also called as metastatic cervical lymphadenopathy, so you do another surgery which is called radical neck dissection. Means you clear the neck totally radically of all the cancer cells. So what are the structures which are removed in R&D? And let's make a list of that. Okay. Now, let me tell you, let's revise once again. What are the structures removed in R&D? Structures removed in R&D are. What is R&D, beta? Radical neck dissection. Structures removed in R&D are. Okay. Now, number one structure is level 1 to level 5 neck nodes. Level 1 to level 5 neck nodes, beta. Number 2, sternocleidomastoid muscle. Number 3, internal jugular vein. Number 4, accessory spinal nerve, means 11th nerve. Number 5, the submandibular gland. Submandibular gland. Number 6, tail of parotid gland. Tail of parotid gland. And number 7 is omohyoid muscle, beta. Omohyoid muscle. Omohyoid muscle. Let's revise once again. What are the structures which are removed in radical neck dissection? Number 1, level 1 to level 5 neck nodes. Number 2, sternocleidomastoid muscle. Number 3, internal jugular vein. Number 4, accessory spinal nerve. And number 5, submandibular gland. Number 6, tail of parotid gland. And number 7 is the omohyoid muscle also. Omohyoid muscle also. Okay. So radical neck dissection, you clear the neck radically of all the cancer deposits or the possible cancer deposits. So you remove the neck nodes. Along with that, you remove all those important neck structures which are coming in contact with these neck nodes. Beta. Okay. But the question is about which structure is not removed in R&D, beta. Now you see this not. Please don't miss the word not. Okay. Be attentive in the paper. Don't miss the keywords. Not. Internal jugular vein, yes, it is removed. Sternocleidomastoid, yes, it is removed. Accessory spinal nerve, yes, it is removed. But digastric muscle is not removed. Answer is digastric muscle. So you remember, omohyoid muscle is removed. Sternocleidomastoid muscle is removed, but digastric muscle is not removed. Beta. Okay, am I clear, beta? Fine. So this was the third question, beta. Now, the fourth question. A carcinoma larynx patient presents to emergency with stridor and respiratory difficulty. You know, stridor means whenever the air passage is narrow, there is extra sound, and that is called stridor. So basically, it is airway emergency. So get ready for such question in the paper in different specialities actually, where they will tell you primary diagnosis cancer larynx, but right now the patient has come with a very severe airway problem. So patient is suffering from carcinoma larynx, yes, but what is the immediate problem right now is the stridor and respiratory difficulty. The emergency medical officer has planned to do an urgent tracheostomy. Urgent tracheostomy has been planned in this patient. What should be the best level of tracheostomy in this case? Now, tracheostomy in a patient of carcinoma larynx is done at what level? The answer of this question is first and second tracheal ring. First and second tracheal ring. Beta. This is the answer. First and second tracheal ring. The C is the answer. Beta. First and second tracheal ring. Is fourth and fifth ring, third and fourth ring, first and second rings, second and third ring. Now the answer is first and second tracheal ring. Okay, that's the answer. Now let me revise with you. What is the most common site of tracheostomy? Most common site of tracheostomy is second and third tracheal ring. Most common site of tracheostomy is second and third tracheal ring. Beta. Second and third tracheal ring, and this is called as mid tracheostomy. Mid tracheostomy. This is called mid tracheostomy. Everybody look at screen, beta. Everybody look at screen. Please see. This is your thyroid cartilage. This is your cricoid cartilage. This is the first tracheal ring, second tracheal ring, third tracheal ring. So generally, most commonly, we do tracheostomy at second and third tracheal ring. This is where we make a hole. And this type of tracheostomy is called mid tracheostomy, MID, mid tracheostomy. Mid tracheostomy. Why we leave the first ring? So as to prevent any damage to larynx beta. Okay. But in laryngeal cancer, which is this patient also, this question is about laryngeal cancer, we do high tracheostomy. In laryngeal cancer patient, we do high tracheostomy beta. High tracheostomy means which is done at first and second ring beta. If you are doing tracheostomy at first and second ring, this is called high tracheostomy beta. High. So what is the indication of high tracheostomy? Is cancer larynx patient presenting with the respiratory difficulty. So let me revise again with you. The most common site of tracheostomy is second and third tracheal ring, and this is called mid tracheostomy. But there is another tracheostomy called high tracheostomy, which is done at first and second ring, and high tracheostomy is done for cancer larynx patient. Cancer larynx patient, don't forget that. Cancer larynx patient, you do high tracheostomy, and that is done at first and second tracheal ring. Am I clear? Fine. Now, let's go back to the question again, beta. Everybody, let's see. Once again, he's saying, carcinoma larynx patient presents to emergency with stridor and distress of respiration, respiratory difficulty. What is the best level of tracheostomy? This is again, now the answer is first and second tracheal ring, and I hope you know this is called as high tracheostomy. High tracheostomy, okay? But most commonly you do the tracheostomy second and third tracheal ring. This is the most common site, and this is called mid tracheostomy. Okay, MID, mid tracheostomy. But for laryngeal cancer, you do high tracheostomy at first and second tracheal ring. Am I clear? Fine. Now, next question. Everybody, next question. Now, Komal, 4-year-old child brought to ENT OPD with complaint of persistent and progressively increasing hoarseness of voice for last 6 months. Her laryngeal endoscopy is shown in the picture. What is the probable diagnosis? Please see, Komal, 4-year-old child. Please see, 4-year-old child, especially. Sometimes they give you a clue, but a 4-year-old child, okay? And the patient is suffering from persistent and progressively increasing hoarseness of voice for last 3 months. It is not 1 day, 1 week problem. For last 3 months, the patient is having, hoarseness of voice, which is persistently increasing in severity also. And there is an endoscopic image given over there. Please see, this is an endoscopy image. Now, the answer of this question is very typical question. The answer of this question is juvenile papilloma of larynx. Juvenile papilloma of larynx. Look at the screen. Juvenile papilloma. Can you see juvenile papilloma? Now, juvenile word has a clue. Juvenile means it is seen in young children, mostly 4 to 6 years. 4 to 6 years. Okay. Papilloma word reminds me, it is caused by human papilloma virus type 6 and 11. And that leads to formation of what? These kind of what? What are they? They are viral warts in the larynx. They lead to what? They're what? Viral warts in the larynx. Can you see? On the vocal cord, there are multiple warts. You know, HPV causes genital warts. Similarly, in the larynx, it can cause viral warts on the vocal cord. Okay, HPV 6 and 11. Okay, fine. Now, if you remember, they can also spread to trachea and bronchi. Okay, they can go down to trachea and bronchi also. Okay, now juvenile papilloma of larynx. Look at the name. Juvenile means it is seen in 4 to 6-year-old child. Papilloma means it is caused by human papillomavirus. Examination shows that viral warts on the vocal cord. Okay, and the treatment for this disease, if you remember, it is microlaryngeal surgery with CO2 laser. Remember CO2 laser beta, MLS with the which laser? CO2 laser beta. MLS with which laser? CO2, carbon dioxide laser beta. What is MLS? Microlaryngeal surgery with which laser? Carbon dioxide laser. And can you tell me beta, which is the most commonly used laser in larynx surgery? Carbon dioxide laser. Most commonly used laser in larynx surgeries is what? Carbon dioxide laser. And what is the wavelength of this laser? 10,600 nanometer. What is the wavelength of this laser? Is 10,600 nanometer. Okay, so the answer of this question is Juvenile papilloma of larynx. Look at screen. Now see the question again. Beta. Please see 4-year-old child. First clue. Beta. Juvenile. Persistent and progressively increasing hoarseness of voice for last 6 months. Beta. Any young child with chronic hoarseness of voice. The first possibility in MCQ is juvenile papilloma of larynx. Once again, beta, any young child of 4 to 6-year-old age with chronic hoarse voice, first possibility should come to your mind is the juvenile papilloma of larynx. Beta. And if they give you this kind of image, and that's definitely the answer is juvenile papilloma of larynx caused by HPV 6 and 11. Beta. Am I clear, beta? Fine. Okay. Now the next question. Very possible questions in the paper. Look at the question, beta. Ritesh, 32-year-old mathematics teacher. Mathematics teacher are aggressive teacher, is teaching in public school for last 12 years. A public school, a government school, and where you got, a lot of students in one class. Lately has been taking frequent, long, uninterrupted sessions before the final examination of students. So he has been a very passionate teacher. He has been really devoted teacher, and he is now taking extra classes in the school for the students to teach them, the final, the final punch before the exam. And like this one is the final punch before the exam, I would say. It's a frequent, long, uninterrupted session before final examination. But now he is himself suffering actually. He has been complaining of hoarseness of voice for last 1 month. Okay. And his laryngeal endoscopy picture is given in the image. And what would be the best management? Steroid therapy, CO2 laser, microlaryngeal surgery, or voice rest? Let me tell you the answer of this question. First of all, what is the diagnosis? The diagnosis of this is vocal nodule. Beta. Okay, look at the picture. It's a vocal nodule. Can you see vocal nodule? Beta? Can you see vocal nodules? Can you see small nodular elevation on the vocal cord? Yes. And everybody, what is the other name of vocal nodule? Is Singer's nodule or teacher's nodule. Mathematics teacher, not teacher's nodule. Beta. There are a lot of clues in the question, beta. Singer nodule, teacher's nodule, also called as screamer's nodule, beta. Screamer's nodule. So singer's nodule, teacher's nodule, or screamer's nodule is other name of vocal nodule, beta. And the most important thing is there is a history of vocal abuse. I hope you remember the most common cause of vocal nodule is vocal abuse. And vocal nodule are always bilateral. Always bilateral, beta. Can you see? They are always bilateral and site junction of anterior 1/3 with posterior 2/3. So what is the site of vocal nodule? Junction of anterior 1/3 and posterior 2/3. Beta. Okay. So vocal nodule are also called as singer nodule, teacher nodule, screamer nodule. Basically, there is a history of vocal abuse, like a mathematics teacher taking very frequent sessions, and they are bilateral and they are lying at the junction of anterior 1/3 and posterior 2/3. What is the chief complaint? Hoarseness of voice. Beta. Okay. And treatment of vocal nodule is the very, very important question. Treatment is voice rest or speech therapy. Don't write surgery. Is either voice rest or speech therapy. Voice rest or speech therapy. Beta. Voice rest or speech therapy. Am I clear, beta? Voice rest or speech therapy. Okay. Fine. Now look at the question again, beta. Let's look at the question again. Ritesh, a 32-year-old mathematics teacher. Okay, there's a clue. Mathematics teacher, beta. Okay, and he has been taking frequent uninterrupted session. Matlab vocal abuse history there. What is the problem? Hoarseness of voice, beta. Endoscopy picture, what? Vocal nodule. So answer is what? Voice rest. Beta. Don't mark surgery. Either it is speech therapy or it is voice rest. Beta. Speech therapy or voice rest is the management of choice for vocal nodule. So this patient is diagnosed as vocal nodule. Beta. Okay. This is what the paper is going now in the direction of clinical paper, conceptual paper, and the image-based question along with the clinical story. Beta. But believe me, they are not that difficult as they look like. They look 1 kilometer long. Don't look at this question, beta. It looks 1 kilometer long question. But if you really can, appreciate one thing, that there is some clue in the mathematics teacher, hoarse voice, some image given. So, and he's asking not a diagnosis, he's asking the management. Beta. Okay. So voice rest. Okay. So the answer of this question is voice rest. Now, next question. Which of the following cannot be seen on indirect laryngoscopy? Indirect laryngoscopy, beta. Which of the following cannot be seen on indirect laryngoscopy, beta? Look at screen, beta. What is indirect laryngoscopy? If you remember, we have a mirror called indirect laryngoscopy mirror. This is called H/L mirror, indirect laryngoscopy mirror. Okay, we warm the mirror first. First of all, you warm the surface so that there is no fogging of the mirror when you use it. Then you use this mirror and you put the mirror in the patient mouth after holding the tongue, and you see the image of the mirror, image of the larynx in the mirror. Basically, you're not seeing the larynx, you're seeing the image of the larynx. Okay, so it is indirect laryngoscopy. Okay, now he's asking what all structures cannot be seen on indirect laryngoscopy. Which structure cannot be seen? Okay, the answer of this question is, of course, anterior commissure. This structure cannot be seen. Anterior commissure cannot be seen on indirect laryngoscopy. What are the other structures? Look, this is number one. Number two, let me complete the list for you. Okay, let me write the list for you. The list. Okay, the number one is anterior commissure of vocal cord. Everybody revise with me, beta. Anterior commissure of vocal cord. Beta. Okay. Number two, laryngeal surface of epiglottis. Laryngeal surface of epiglottis, which is also called under surface. Beta. Under surface. Number three, everybody speak up with me. Under surface of vocal cord and adjoining area of subglottis. And adjoining area of subglottis. Adjoining area of subglottis. Okay. Number four, you cannot see ventricle. If you remember, ventricle is the space between the true cord and the false cord. Number five, saccule. You cannot see saccule, saccule. Number six, you cannot see apex of piriform sinus. You also cannot see apex of piriform sinus. I know you know all these things, but it's a quick revision, beta. Okay, it's a quick revision. Basically, what structures cannot be seen on indirect laryngoscopy are anterior commissure of vocal cord, laryngeal or under surface of epiglottis, under surface of vocal cord, and adjoining area of subglottis. Number four, ventricle. Number five, saccule, and lastly, apex of piriform sinus. Okay, so these structures cannot be seen on indirect laryngoscopy. Answer is cannot be, na? Cannot be. So answer is A, beta. Okay, rest all these three can be seen. Okay, can be seen, beta. Can be seen. Am I clear, beta? Fine. Here I want you to know one image-based question. There are two mirrors in ENT. One mirror is called indirect laryngoscopy mirror. Other mirror is called posterior rhinoscopy mirror. Indirect laryngoscopy mirror or posterior rhinoscopy mirror. The first one is indirect laryngoscopy mirror. How to really see? It's a straight mirror, beta. And number two is posterior rhinoscopy mirror. And how to differentiate? It's an angulated mirror. Can you see it's angulated, beta? Please see. Indirect laryngoscopy mirror is a straight mirror, beta. Straight. But posterior rhinoscopy mirror is angulated mirror, beta. Can you see it's angulated mirror? Posterior rhinoscopy mirror is angulated mirror. Okay, fine. Chal. So this is a differentiation of two mirror, beta. Okay, how to remember? Indirect laryngoscopy mirror is a straight mirror. Posterior rhinoscopy mirror is an angulated mirror. Okay, bache, fine. Chal. Now, everybody, one more visual question, beta. What is this? This is the tongue depressor, which we use very commonly in the ENT OPD. Okay, what is the full name? Lax tongue depressor. If you get an image-based question in your paper, like this kind of instrument shown in your exam, and they ask you this L kind of thing, in ENT OPD instrument, what's the name of instrument? It's a lax, LACK, lax tongue depressor. It's a lax tongue depressor. Okay, now question number 8. 45-year-old female was operated for emergency appendectomy under general anesthesia. So she has undergone emergency appendectomy under general anesthesia. Okay. After surgery, she is complaining of hoarseness of voice. So basically, after the surgery of appendectomy under general anesthesia, she is complaining of hoarseness of voice. What can be the etiology of this hoarseness in this patient? Please don't think about appendectomy. Please don't confuse yourself with the word appendectomy. It has been put to confuse you. The real word is general anesthesia. You know, GA, you know, general anesthesia needs intubation. Intubation. And while intubation, the anesthetist may injure the vocal cord. While intubation, the surgeon may injure the vocal cord, and that injury can lead to a problem called intubation granuloma. Can you see the interesting clinical story-based question, beta? Appendectomy may be very, lucrative word for you, but the real word is not appendectomy. The real word is general anesthesia, GA, which needs intubation. So that intubation would have led to some injury on the vocal cord, and that injury has caused the intubation granuloma. Okay, intubation granuloma. So don't get confused with appendectomy. Think about general anesthesia. So this patient has got hoarse voice due to intubation granuloma beta. So what's the answer? Intubation granuloma beta. Let's see the intubation granuloma beta. Please see. Again, this is always bilateral beta. Once again, it's always bilateral. But the location is the junction of anterior 2/3 and posterior 1/3 beta. Anterior 2/3. Anterior 2/3 and posterior 1/3. If you remember, vocal nodules are also bilateral, but they are lying at the junction of anterior 1/3 and posterior 2/3. Intubation granuloma is lying at the junction of anterior 2/3 and posterior 1/3. Okay. What is the treatment offered to this patient? The treatment for this patient is MLS. What is MLS? Micro-laryngeal surgery. MLS, micro-laryngeal surgery. Basically, MLS is surgery of vocal cord under microscope. Micro-laryngeal surgery. So the key word in this question is not appendectomy. Please don't forget, it is actually general anesthesia, GA. And GA needs intubation. Okay. Okay. So that's an interesting scenario now. This is what the paper is all about, beta. That you have to be really vigilant what they're asking. Huh? Now, 3-month-old baby. Next question. 3-month-old baby presents with inspiratory stridor almost since birth. 3-month-old baby presents with inspiratory stridor almost since birth, beta. The cry of baby is normal. The cry of baby is normal, beta. The stridor decreases in prone position. What is the possible diagnosis, beta? Vocal cord paralysis, epiglottitis, laryngotracheobronchitis, laryngomalacia, beta. Please see, what is the key word, beta? The patient is suffering from inspiratory stridor almost since birth. When some question says problem is since birth, think of congenital abnormality of that particular part of the body. Whenever any MCQ in any specialty points a finger like that, okay, this problem is since birth, then you think about that most probably the disease would be some congenital disorder actually. And do you know which is the most common congenital disease of larynx? Laryngomalacia. So the answer is laryngomalacia. Laryngomalacia is the answer, beta. If you remember, laryngomalacia is the weakness of supraglottis, beta. Is the weakness of supraglottis. Do you remember, beta? It gives you what type of epiglottis? Omega-shaped epiglottis, beta. Omega-shaped epiglottis is a feature of laryngomalacia. What type of stridor it causes? The stridor would be having 4 things to remember. So what is stridor? Noisy breathing. Number 1, it will be inspiratory stridor. Okay. Number 2, it starts within a week after birth, beta. So basically, it's very, very, early in onset, means right after birth, beta. Number 3, it increases on crying, beta. Okay. And number 4, it decreases in prone position. Prone position. The stridor has got 4 points to remember. Laryngomalacia stridor is inspiratory. It starts immediately after birth, within a few days after birth. And number 3, it increases on crying and decreases in prone position. Okay. Okay, beta. So he has given you all sort of clue. Beta. Once again, see the question. 3-month-old baby. Okay, beta. 3-month-old baby. Okay. And you see, beta, all inspiratory stridor. Okay. Almost since birth. The cry of baby is normal. The stridor decreases in prone position. Okay. You remember the stridor is inspiratory. Stridor increases on crying, decreases in prone position. What is the possible diagnosis? Laryngomalacia, beta. Laryngomalacia is the weakness of supraglottis, beta. In laryngomalacia, vocal cord are normal. vocal cord are normal. It's only the weakness of supraglottis, upper part of larynx, beta. Vocal cord are normal, therefore cry is normal, beta. The cry of this baby is also normal, beta. This is a very possible clinical scenario based question in the paper, beta. So once again, laryngomalacia is the most common congenital disorder of larynx. It is a weakness of supraglottis. Okay, but vocal cords are normal, so cry of the baby is normal. The cry sound comes from the vocal cord, beta. Okay, the main problem in this patient is stridor. 4 point about stridor are: it is inspiratory stridor, it starts immediately after birth, it increases on crying but decreases in prone position. Examination shows what? Omega shaped epiglottis. Okay, and the treatment, that's MCQ. The treatment of this patient, never forget the treatment of this patient. The treatment of this patient would be conservative, no surgery, beta. Don't worry, beta. There is no cyanosis of the baby. Only stridor is there, which is only a sound, beta. Treatment is conservative. Matlab means that's MCQ, very common question. What's the treatment of laryngomalacia? Conservative. That is, reassure the parents that it is self-limiting condition. Reassure the parents that it is self-limiting condition, beta. Am I clear, beta? So laryngomalacia, please see the treatment is conservative, means reassure the parents that it is self-limiting condition. Now you can ask me that why it is not B or C, beta. Okay, why it is not B? Why it is not epiglottitis laryngotracheobronchitis? Please see, beta. Both of them are acute infections. Beta. Acute infection. Very short history. This problem of the baby since birth, 3-month-old baby since birth, 3 months problem. No. Epiglottitis, laryngotracheobronchitis are acute problem, beta. They are very severe problem. Lot of airway issues are there. And number 2, patient will be having fever, beta. Fever. It's infection, now. There will be fever, respiratory difficulty, these kind of symptoms will be there, and a very acute kind of infection, beta. 1 or 2 days history only, beta. Okay, so it cannot be epiglottitis or laryngotracheobronchitis, beta. Anyway, it cannot be vocal cord palsy because the cry of the baby is normal. The cry sound comes from vocal cord. In this case, vocal cord palsy cannot be there, beta. Okay, because vocal cord problem means sound will be a problem. Now, cry is a sound, now. So the problem is since birth. Stridor is inspiratory. The stridor decreases in prone position. All these are clues for laryngomalacia, beta. And treatment of laryngomalacia is conservative. That is, reassure the parents that it is self-limiting condition. Okay, fine. Now, next problem, next question. 10th question, beta. 20-year-old male patient has high pitch voice. 20-year-old male patient has high pitch voice, beta. First of all, male should have low pitch voice. Male should have a low pitch voice. Normal male should have a dull voice, like my voice, Amitabh Bachchan's voice or anybody else's voice, but a dull voice. Male should have low pitch voice, but male with a high pitch voice, it's a disease called puberphonia. Please understand, male should have low pitch voice. A male having high pitch voice is a disease called puberphonia. His endoscopy is normal, no problem on vocal cord. The clinician has advised him speech therapy. What is the name of the maneuver for speech therapy, beta? Remember, the name of maneuver is the Gutsman maneuver, beta. Gutsman. For puberphonia, the main treatment is speech therapy. And for speech therapy, you do a maneuver called Gutsman maneuver, beta. Look at me, beta. How we do Gutsman? You press your thyroid cartilage backward and you speak. Basically, you hold the thyroid cartilage, pull it a little downward, press it backward, and then speak, beta. By pressing the thyroid cartilage backward, you're pressing the vocal cords also. And vocal cord will become loose, and a loose cord will produce low pitch sound. Please do remember physics, beta. Tight things produce high pitch sound. Loose things produce low pitch sound. I want low pitch sound, beta. Okay. So once again, a male having high pitch voice is a disease called puberphonia. The main treatment of this is speech therapy. For speech therapy, we do a maneuver called Gutsman maneuver. And in Gutsman maneuver, we press the thyroid cartilage backward and speak. Okay. And if speech therapy fails, then we do type 3 thyroplasty. And type 3 thyroplasty, if you remember, we also discussed earlier also, type 3 thyroplasty is actually shortening or loosening of vocal cord. Type 3 thyroplasty is shortening or loosening of vocal cord, beta. Am I clear, beta? Fine. Okay. Now, 11th question. 20-year-old male patient has high pitch voice. Sorry, the answer of this question is, sorry, the guts will maneuver, beta. The 10th question, 11th question, beta. 23-year-old young man, member of music band. He's a member of music band, beta, okay? Now, who plays saxophone? You know saxophone, the instrument with the, wind-based instrument for last 10 years. The band has been doing many popular concerts. He has developed a neck swelling on the left side of the larynx. The X-ray of the neck is shown in the picture. What is the possible diagnosis? Can you see, beta? The saxophone, beta. It's a wind-based instrument, beta. Okay? People who play wind-based instrument like Shanai or trumpet or flute, these kind of things, beta, where they build a lot of pressure in the throat, they can develop a swelling of the larynx called laryngocele, beta. Laryngocele. Okay, in the X-ray, can you see that, beta? Can you see the X-ray neck? Can you see an air-filled swelling here, beta? This air-filled swelling is laryngocele, beta. This is laryngocele. This is X-ray neck of the patient, and this is actually laryngocele, beta. Okay. Now let me quickly go through what is laryngocele, beta. So answer is laryngocele. If you remember, saccule is a normal structure, beta. If you remember, saccule is a normal structure. Saccule is actually an outpouching from ventricle, beta. Okay. This is a normal anatomy, beta. But if saccule becomes very big in size, if saccule increases in size, it's a disease called laryngocele, beta. Laryngocele, okay? Now please see on the screen, beta. Can you see the saccule become a balloon and filled with the air, beta? Air, okay? Air, okay? And this large saccule is called laryngocele. Everybody, one more MCQ of anatomy. What is laryngocele? A large saccule. Saccule is a normal structure. A large saccule is a disease called laryngocele. So laryngocele develops from saccule. Laryngocele develops from saccule, beta. Okay, fine. Am I clear? Now, laryngocele is seen more commonly in wind instrument blower, beta. Wind instrument like saxophone is a wind instrument, beta. Okay. It presents as air-filled neck swelling. If you see, beta, it presents as air-filled neck swelling. Can you see, beta? The patient has got air-filled neck swelling, beta. Okay. That's a swelling, beta. Here is a swelling. Okay, fine. It presents as air-filled neck swelling, beta. Okay. If you press this swelling, air leaks, beta. If you press the swelling, air leaks, and that produces sound actually. If you press it, the air leaks, and this is called Bryce's sign, beta. Okay. On pressing the laryngocele, the sound of air leak can be heard, and that's called Bryce's sign because it's an air-filled neck swelling, beta. Air-filled neck swelling. Okay. So this is the person swelling, beta. And what he's doing right now, what is the person doing? He's closing the nose and just trying to exhale. This is called Valsalva. You know Valsalva? You can see the swelling better on Valsalva. You know what is Valsalva? Close your nose, close your mouth, and try to exhale. Forceful expiration against closed nose and closed mouth. Look at me, beta. Look at me. When you do like, you try to fill some air in your system when your nose and mouth are closed, forcible expiration against closed nose and closed mouth is called Valsalva. So this swelling can be better seen on Valsalva, and X-ray neck on Valsalva. X-ray neck on Valsalva will show a very obvious swelling over here, and that's an air-filled swelling, and that's called laryngocele. So some question about laryngocele. It is actually large saccule. It is more common in wind instrument blowers. Number 3, it can be better seen on Valsalva. And number 4, it is air-filled neck swelling. When you press, air leaks, and that's called Bryce's sign, beta. And X-ray neck is done on Valsalva, beta. Valsalva. Okay. Please do remember this can be a clinical question along with a story, along with something written in addition to that. Now once again read, beta. 23-year-old young man, saxophone player for last 10 years, beta. Okay. And he has developed neck swelling on left side of pharynx. X-ray neck is shown in the image, beta. This is X-ray. And so answer is laryngocele. Air-filled neck swelling, beta. Okay. Laryngocele. Now, next one, beta. Next one, everybody. Okay. 12th question, beta. 55-year-old woman has been suffering from COPD, neuromuscular respiratory insufficiency also. 1 week back, she underwent tracheostomy. 1 week back, she underwent tracheostomy for airway support and bronchial toilet. Toilet with the cleaning. Bronchial toilet means cleaning because the patient is suffering from COPD, a lot of secretion are there, and there is respiratory insufficiency also. The patient is unable to breathe properly. And so you've done tracheostomy to give the airway support. She's now in the ward. In the morning round, you find that tracheostomy tube is blocked and her SpO2 is 72%. Matlab airway emergency. The tube is blocked, but unfortunately, The tube is blocked. Secretions are deposited inside the tube and the tube is blocked. What would be the immediate management would you like to carry out? Would you start the oxygen? Would you give injection dirophyllin? Would you do suction of tube after putting normal saline in the tube? Or you remove the tube immediately? The answer of this question is remove the tube immediately. Please, please, please do not try to do any suction. The tube is filled up with dried, crusted secretions, which won't come out easily with the suction. And don't waste time. Patient is already having hypoxia. SpO2 is 72% beta. Okay, patient is unable to breathe. The patient is in a very critical state. It's an airway emergency. Please remove the tube immediately and put a new tube little later, beta. Please remove the tube immediately and put a new tube later, beta. Am I clear, beta? So answer is remove the tube immediately. Don't give oxygen. How the oxygen will help the patient now? Because tube is already blocked, beta. Okay, fine. So answer is remove the tube immediately. Okay, fine. Now, next one. 13th question, beta. A 3-year-old child has been brought to pediatric emergency with history of fever, respiratory difficulty, stridor, drooling of saliva since yesterday. The child is in a very critical situation with SpO2 level of 80%. Okay. What would be your immediate management of this patient? Please understand, 3-year-old child, first of all, fever, infection is there. Respiratory difficulty, airway problem is there. Okay. Stridor, again airway problem. Drooling of saliva, something in the throat is there. Okay. Now let me tell you, this is a very sick child. The child is in a very critical situation. Please do remember, this patient is suffering from acute epiglottitis. This is the typical story of acute epiglottitis. Don't forget, epiglottitis is more common in 2 to 7-year-old age child. 2 to 7 year age is the age for epiglottitis baby. There is fever, infection, respiratory difficulty, airway problem, stridor, airway problem, drooling of saliva, throat is having painful, problem. Critical state, critical situation. Epiglottitis is a very sick baby, and this patient will be having a very huge airway problem. What would be your immediate problem is, don't go for X-ray. Don't give antibiotic. Antibiotic will take 12 hours to act. Urgent intubation is the answer. Please do urgent intubation. And don't do repeated laryngoscopy. But remember, the repeated laryngoscopy should be avoided, because in epiglottitis, if you do repeated laryngoscopy by direct laryngoscope, it will increase the edema. In epiglottitis baby, the repeated direct laryngoscopy should be avoided, because that can increase the edema. It's an airway emergency. So in this case, please put the intubation. So the most urgent treatment of acute epiglottitis baby is airway management. Please don't forget this question. This question can come in pediatrics as such. So 2-year-old child, respiratory difficulty, stridor, fever, SpO2 down, hypoxia, critical state of baby, all of these are indicating towards the acute epiglottitis situation. And the first and most important treatment for this patient is airway management by intubation. If you remember, X-ray neck of this baby will show thumb sign. Remember, X-ray neck in a patient of epiglottitis, if you do actually, is thumb sign. But X-ray is not my priority right now. My priority is to save the baby first. But however, if you do X-ray of the neck, you can see epiglottis swollen like a thumb. This is called thumb sign. Okay, fine. Now, 14th question. Suhani, 19-year-old college-going girl, has presented to emergency with sudden loss of voice. Please don't look at the question, beta. Young girl with sudden loss of voice is functional aphonia. Beta. Remember, functional aphonia, also called as hysterical aphonia. Also called as hysterical aphonia. Functional aphonia, also called as hysterical aphonia. Beta. This is typically seen in young females. Do you remember, beta? A young female with sudden loss of voice is functional problem, psychological problem, not organic problem. There's no problem in the patient. Patient is doing acting of not speaking, beta. So young female with sudden loss of voice, the answer is functional aphonia. How to prove the diagnosis? Cough sound is normal. The person who can cough can speak also. Look at the screen, beta. Her cough sound is normal. This is another clue for functional aphonia, beta. Okay, beta. Young girl with sudden loss of voice is functional aphonia. Beta. Suhani, young girl, 19-year-old girl, sudden loss of voice, cough sound normal. Of course, functional aphonia is the answer. It's also called as hysterical aphonia. Beta. Hysterical aphonia. Okay, fine, beta, fine. And what's the treatment of functional aphonia? The treatment of this condition is psychotherapy. It's a psychological condition. Huh? There is no need of any surgery or speech therapy. Psychotherapy is the treatment. Okay, it is a psychological condition. Beta. Okay, now next question, beta. A singer has undergone thyroid surgery 1 month back. 1 month back. Her recovery has been satisfactory, except that she is unable to sing higher notes now. Higher notes mean frequencies. Singer patient, beta, singer. Okay, thyroid surgery 1 month back, but she is unable to sing the higher notes now. What is the possible nerve injury which could have happened during thyroid surgery of this patient? Beta? Please understand. I told you the thyroid gland has got two relations. The lower pole has got RLN, the upper pole has got SLN. Beta. Now, the answer to this question is superior laryngeal nerve injury. Beta. That's the answer. D. But why? Now, if during thyroid surgery, superior laryngeal nerve got cut, it got cut. Okay. Now, whenever SLN gets cut, okay. Now, cricothyroid muscle is gone, beta. Cricothyroid muscle is gone. I hope remember the famous statement of larynx. All muscles of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. So surgeon has accidentally damaged superior laryngeal nerve. So cricothyroid muscle function is lost. Am I clear? Now, this is the main tensor of vocal cord. It's an adductor also. Adductor, A-double-D, adductor. It's also the main tensor. Beta. When the tensor are gone, examination will show bowed down vocal cord. The cord will be bowing down. The cord latak jayenge. They will be little less tense. You know, look at my hand, beta. They will be little less tense. They will just droop down like this, little bit. Less tense, like they will droop down, bow down, jhukna, latak jana, bow down vocal cord. Because tensor is gone. So examination shows bow down vocal cord. That's also MCQ beta. Okay. And what will be the chief complaint of this patient? Poor quality of voice, beta. Poor quality of voice. Poor quality of voice, beta. Poor quality of voice, beta. Please understand, because if you remember, tensors give you quality of voice, beta. Tensors give you quality of voice, beta. Okay, and examination shows bowed down vocal cord. So, to MCQ, if SLN is injured during thyroid surgery, the cricothyroid muscle function is lost, and it is the main tensor of vocal cord. So, examination will show bowed down vocal cord, and the patient will complain of poor quality of voice. That if he's a singer, he can tell you, doctor, I'm unable to sing the higher note. This is a poor quality of voice. This is indicating poor quality of voice. Am I clear, beta? This is indicating poor quality of voice. The patient undergone thyroid surgery. Okay, no major problem. Only thing is that unable to sing higher notes. So poor quality of voice. So which nerve is responsible? Superior laryngeal nerve injury, beta. Okay, beta, fine. Now these were the 15 question of larynx, beta. 15 question of larynx, beta. Okay. Okay. Now let's go to the next segment. The next segment is about the nose, beta. Now next 15 question will be of nose. Okay. The scheme of the paper will be 15 question of larynx, 15 of nose, 15 of pharynx, and then remaining 25 question are of the ear actually. Okay. So keep revising, beta. It's a long session, I know, but my purpose of doing this session is that you are able to keep your notes in front of you, which you have made in the class when you attended the class with me. And now you're actually trying to, rerun the whole story in your mind with a clinical angle in your mind, because this is what the future is. This is what the paper is all about now, so that we have the, main things, clinical things very crystal clear in our mind. Actually, did you notice that 15 questions are stories actually? Okay. But not difficult, not difficult. Only thing is you have to be vigilant enough to pick up the keyword, think on the very, the straight lines and go to the answer bit. Okay. 23-year-old person suffering from acute frontal sinusitis has developed a painful red forehead swelling. Painful red forehead swelling, which is the following is the possible diagnosis. All of you think about it. Think about it. Orbitocellulitis, Ringett's tumor, Pott's-Mayfield tumor, or osteoma of the frontal sinus. Think about it, beta. Anybody? Can you tell me? 23-year-old person suffering from acute frontosinusitis has developed painful red forehead swelling. Painful red forehead swelling, beta. Okay, which is following is a possible diagnosis. Answer is Pott's puffy tumor, beta. Pott's puffy tumor, beta. Can you see Pott's puffy tumor? Now, Pott's puffy tumor, beta. Look at screen. Frontal sinusitis is the main problem, and that leads to the frontal osteomyelitis, and that will lead to subperiosteal frontal abscess. That lead to subperiosteal frontal abscess, and that is called as Pott's puffy tumor. Don't forget this one, very probable question. Pott's puffy tumor, the background of the patient will be, patient is suffering from acute frontal sinusitis. The presentation of Pott's puffy tumor is red, painful forehead swelling. Red, painful forehead swelling, beta. Okay, so once again, read the question with me, beta. Patient is suffering from frontal sinusitis. Patient develop painful red forehead swelling. Answer is Pott's puffy tumor, beta. Please don't forget this one. Very possible clinical scenario based question, beta. Okay, Pott's puffy tumor, very catchy word. It's not a tumor. It's only infection of the frontal bone, which leads to subperiosteal frontal abscess. Okay, remember, beta. Pott's puffy tumor is not a tumor. It is actually subperiosteal frontal abscess, which looks like this, beta. Okay. Now the next one, beta. Everybody, next one. 17th question, beta. 43-year-old male patient presents with roomy nasal cavity, nasal crust, and disfigured hard external nose. Biopsy from the nose is shown in the image. What is the diagnosis, beta? Please understand, beta. The moment you read these two words in nose question, roomy nasal cavity, crust formation, suddenly only one thing comes to my mind is atrophic rhinitis, beta. But with disfigured hard external nose, hard. Remember, hard means woody. And the answer to this question is rhinoscleroma, beta. Rhinoscleroma. Do you remember, beta? Rhinoscleroma is also called as woody nose, beta. Woody nose, beta. Rhinoscleroma is also called as woody nose. Remember, rhinoscleroma also called as woody nose, beta. Let me tell you a trick to solve question, beta. Rhinoscleroma MCQs can be confused with the MCQ of atrophic rhinitis, because atrophic rhinitis also has crust. Rhinoscleroma also has crust. Atrophic rhinitis also has got wide roomy cavity. Rhinoscleroma also has got wide roomy cavity. Atrophic rhinitis also has got atrophio turbinate. Rhinoscleroma also has got atrophio turbinate. But one difference is, in atrophic rhinitis, there is no outside change in the look of the nose, beta. In the feel of the nose. Okay, in the look of the nose, from the external nose, there is no change in the look of the nose. But in rhinoscleroma, if you look at the patient, there are multiple granulomas formation in the external nose, which lead to thickening of the nose, and that feel of the nose, the look of the nose is called woody nose. Beta. So rhinoscleroma, also called as woody nose, is the diagnosis. Beta. Once again, beta, please see, patient is having the roomy nasal cavity, nasal crust with disfigured hard external nose, beta. Biopsy is given in the image, beta. Can you see, beta? This biopsy has got no relevance, beta. It is only given to increase the ornamental value of the MCQ, beta. Such kind of question are very much, common over there. So don't think every image is there. Sometimes clinical story is so clear that I know it is rhinoscleroma, beta. It is no rhinoscleroma, beta. I'm a clear beta, rhinoscleroma, beta. But for what is the biopsy finding? Let me tell you. Biopsy shows two things, beta. Russell bodies and Mikulicz cell, beta. So what are the Russell bodies and Mikulicz cell? So these blue things are Russell bodies, beta. Russell body, the blue things, beta. Can you see the Russell bodies, beta? And the large empty cell, vacuolate cell are Mikulicz cell, beta. Russell bodies and Mikulicz cell. Russell bodies and Mikulicz cell, beta. Am I clear, beta? So rhinoscleroma biopsy shows Russell body and Mikulicz cell. Anybody? What is the drug of choice of this patient? Drug of choice is tetracycline plus streptomycin. What is the drug of choice for rhinoscleroma? Tetracycline and streptomycin. Tetracycline and streptomycin, beta. Am I clear, beta? Fine? Okay. Chalo. Next one, beta. Everybody? Now, identify the findings shown in the NCCT, non-contrast CT of nose and paranasal sinuses marked with arrow, beta. Okay, marked with arrow. Please see, is it bullage modalis, Heller cell, concha bullosa, or Onodi cell, beta? Four choices, beta. Now, please look at screen, beta. Look at screen. Can you see the CT scan, beta? This is a CT scan of the nose and sinuses. You see this is orbit. This is brain, beta. Okay, brain. Now, this sinus is called maxillary sinus, beta. This is maxillary sinus, beta. This turbinate is called inferior turbinate. This is called inferior turbinate. Am I clear? Inferior turbinate. Am I clear? Inferior turbinate. Okay. Can you see a cell over here? The cell in the floor of the orbit. The cell in the floor of orbit, if you remember, it is called Heller cell. H-A-L-L-E-R. Heller cell. Heller cell. The cell in the floor of orbit is called Heller cell. H-A-L-L-E-R. Heller cell. Heller cell. Heller cell lies in the floor of the orbit. Heller cell lies in the floor of the orbit. Let's revise the other cells also. This is important, beta. This is very important thing in your paper. The various questions, beta. Bulla ethmodalis. Definition, beta. Bulla ethmodalis is the largest anterior ethmoid ear cell. Okay. Heller cell lies in the orbital floor, beta. The one in the MCQ, the Heller cell lies in the orbital floor. Concha bullosa lies inside middle turbinate. Concha bullosa, concha means turbinate, concha bullosa, bulla means cell. Concha bullosa is an air cell which lies in the middle turbinate. Onodi cell lies close to optic nerve. Optic nerve. And lastly, one more thing, beta, over here is agar-nasai or agar-nasai. Agar-nasai is anterior ethmoid cell. Okay. Agar-nasai, you know, A-double-G-E, A-double-G, आगे, आगे, मतलब सबसे आगे, A-double-G, आगे, A-double-G-E, आगे, beta. Let's revise the 5 cells, beta. Let's revise 5 cells. Number 1, bulla ethmodalis is the largest anterior ethmoid cell. Number 2, Heller cell lies in the orbital floor. Number 3, concha bullosa lies inside middle turbinate. Number 4, Onodi cell lies close to optic nerve. Number 5, agar-nasai is the anterior ethmoid ear cell. Beta. Can we revise once again, beta? Can we revise once again? Now please see, this is Heller cell, beta. Can you see now Heller cell, beta? Heller cell lies in the floor of the orbit. Can you see, beta, this cell, beta? Heller cell lies in the floor of the orbit. Heller cell. Okay, fine, beta. Fine, bache. Fine. Now, let's revise once again. The bulla ethmodalis is the keyword largest anterior ethmoid ear cell. Heller cell in the orbital floor. Concha bullosa in the middle turbinate. Onodi cell close to the optic nerve. Okay, and lastly, agar-nasai is anterior-most cell. Anterior-most, anterior-most anterior ethmoid ear cell. These are 5 ready-made questions. Once again, bulla ethmodalis is largest cell. Heller cell lies in the orbital floor. Concha bullosa in the middle turbinate. Onodi cell close to optic nerve. And agar-nasai is the anterior-most anterior ethmoid ear cell. Okay, now let's go next question. Now, clinical scenario-based question. A patient in ENT examination has been found to be non-responsive to smell of coffee, tea, and asafoetida. Asafoetida is hing. You know, hing is one of the very powerful spice we use in South India, North India, everywhere. Actually, very powerful spice. Hing, if you smell hing, it's like a very, 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 very strong spice. Somebody who is not able to sense the hing even, the patient is suffering from anosmia. The patient is suffering from anosmia. You know, anosmia means total loss of sense of smell. Anosmia. And, you know, anosmia patient can still sense ammonia. You know, ammonia, NH3 chemistry lab, ammonia. A patient of anosmia can still sense ammonia. Why? Because ammonia is not a smell. It is an irritant. It's an irritant. And it is sensed through trigeminal nerve. Fifth nerve. Once again, beta, a patient of anosmia can still sense ammonia. Ammonia. Why? Ammonia is not a smell. Ammonia is an irritant. And it is sensed through which nerve? Trigeminal nerve. Please remember anatomy, clinical anatomy question. Ammonia is sensed through which nerve? Not olfactory nerve. Ammonia is sensed through trigeminal nerve. Trigeminal nerve. I'm clear with trigeminal. Fifth nerve. Okay. So this is a patient of anosmia who can still sense ammonia. Okay. Now the next question, 20th question. The given sign on filter paper as shown in the image is characteristic feature of which clinical condition? Now he's not giving you the name of sign, beta. The given sign on filter paper as shown in the image is a characteristic feature of which clinical condition? First of all, this sign is called as target sign or hello sign. Beta. This sign is called as target sign or hello sign. Beta. This sign is called as target or hello sign. Beta. Hello sign. Okay, it is seen in traumatic CSF leak. Answer is traumatic CSF leak. But why? Now this CSF is blood mixed CSF. This is not a correct. A is not the correct answer. Beta. CS not CSF rhinorrhea, particularly traumatic CSF rhinorrhea. Trauma. Why trauma? Because traumatic CSF leak is blood mixed CSF. Therefore, if you allow a drop of blood to fall on the filter paper, upon drawing, when it dries up, actually, it will leave a central spot, red spot. Around that, there will be a halo actually. So this is called a target sign or halo sign. It is seen on filter paper. It is seen in traumatic CSF leak, not in CSF rhinorrhea. It is seen in traumatic CSF leak. This is the correct answer. Traumatic CSF leak. Beta. Okay. And why? Because it is blood mixed CSF. Beta. This is blood mixed CSF. Beta. Okay. Am I clear? Beta? This sign is called as target sign or hello sign. Beta. It is seen on the filter paper and it is seen in the case of traumatic CSF leak. Beta. So filter paper test. Beta. Am I clear? Beta? Everybody fine? Sure. Now 21. A very possible question beta in the paper. 7-year-old child while playing fell down. He has developed nasal blockage on both sides. Please see nasal. History of trauma. 7-year-old child playing fell down. Trauma. Nasal blockage on both sides. And there is swelling around the nose. Beta. Okay. Swelling around the nose. Now his internal examination is shown in the image. Beta. Okay. Please see. Can you see the internal examination? Beta? Please see. Can you see the internal examination? This is a case of septal hematoma. Beta. This is a case of septal hematoma. Septal hematoma. It's a case of septal hematoma. Beta. You can ask me, sir, why it is not nasal fracture? Why it is not nasal fracture? There is history of trauma. There is history of swelling around the nose. Why there is no history of? Why there is no possibility of fracture in this case? Beta? Because why? Number one, the nasal fracture will have some nasal deformity. They will give you history that outside nose is deformed. There's nasal deformity. Number two, bilateral nasal blockage. This nasal blockage in both sides. Bilateral nasal blockage is a typical thing which goes in favor of septal hematoma. Because septal hematoma is mostly bilateral. Please understand, nasal blockage on both sides is more in favor of septal hematoma. Why septal hematoma is actually mostly bilateral. Beta. Okay. Once again, beta, 7-year-old child while playing fell down. He has developed nasal blockage on both sides and there is swelling around the nose. His internal nasal examination is shown in the image. Beta. And what is the further treatment of this patient? So the diagnosis of this patient is septal hematoma. Why? It is not a fracture case. A fracture would be giving you a history of external nasal deformity due to fracture. He will discuss about X-ray findings also in that case. Beta. Okay. And treatment of septal hematoma is aspiration of septal swelling. Beta. Okay. Aspiration of septal swelling. Don't leave the hematoma. Otherwise, it can convert to septal abscess, which can lead on to septal perforation. Beta. So this is a typical case of septal hematoma, bilateral blockage, beta. Nasal blockage on both sides after trauma. Definite answer is septal hematoma. After trauma, nasal blockage on both sides is septal hematoma question, beta, because septal hematoma is known to be bilateral. Can you see it is both sides, beta? This side and this side, both beta. Bilateral, beta. So treatment is aspiration of septal swelling, beta. Okay, fine. Sure. Now, next question, beta. 22nd question. A male patient, resident of Tamil Nadu, has presented with nasal mass. See the image and epistaxis. Beta. What is the possible diagnosis? Now, please see. This is the resident of Tamil Nadu, beta, South India. There is only one disease in ENT which is more common in southern part of the country, particularly coastal villages of Tamil Nadu, and that disease is rhinosporidiosis. Rhinosporidiosis. Beta. Look at screen, beta. Rhinosporidiosis. Can you see the rhinosporidiosis? The typical appearance of rhinosporidiosis is mulberry-like nasal mass. Beta. Now, rhinosporidiosis would have a typical picture of mulberry-like nasal mass, plus there will be bleeding from there also, plus epistaxis. So, mulberry-like nasal mass plus there will be bleeding also from that, plus epistaxis. Please understand. Let's do beta. Rhinosporidiosis. What are the characteristic finding to really keep in mind? The mulberry-like nasal mass with epistaxis, and this is more common in southern part of the country, particularly coastal villages of Tamil Nadu. Beta. Okay, beta. Please understand. If they give you history of UP and Rajasthan patient from UP, Uttar Pradesh or Rajasthan with nose problem, rhinoscleroma. Rhinoscleroma, the woody nose is more common in Uttar Pradesh, Rajasthan. Rhinosporidiosis is more common in southern India, Tamil Nadu particularly. Once again, rhinoscleroma is more common in North India, that is Uttar Pradesh, Rajasthan, but rhinosporidiosis is more common in South India, that is coastal parts of Tamil Nadu. Okay. What drug is used for rhinosporidiosis? The answer is Dapsone. If you remember, the answer is Dapsone. Okay. After surgery, which drug is given for rhinosporidiosis is Dapsone. Dapsone. Okay. Dapsone. Okay. Rhinosporidiosis, Dapsone. This is rhinosporidiosis. Never forget, mulberry-like nasal mass, epistaxis is rhinosporidiosis. And drug is given is Dapsone. Okay. Fine. Now, the next question, 23rd question. 18-year-old young male was hit with cricket bat on face 2 days ago. Cricket bat trauma. Please see, cricket bat, the cricket bat trauma history 2 days ago, beta. 2 days ago. He has developed nasal swelling. X-ray picture is given in the image, beta. Please understand. Patient has undergone trauma. Patient has gone some trauma. Please see, that's X-ray. Can you see in this X-ray that there is a fracture of nasal bone? Beta? Just see, the nasal bone has got fractured and it has got pressed inward. Now, trauma can lead to septal hematoma, but trauma can also lead to nasal bone fracture, as seen on X-ray. Whenever they give you X-ray finding, think of nasal bone fracture. Beta. Okay. Now the question is, will you go for immediate fracture reduction? Or will you wait for a few days and then you do the fracture reduction? Please understand, if nasal bone fracture is fresh and there's no swelling of the nose from outside, then you do immediate fracture reduction. If there's already swelling there, please understand, in this patient, he has developed nasal swelling. Please see, because fracture is 2 days old. Fracture happened 2 days ago. In 2 days, there'll be swelling, edema and all that. Now the answer will be not immediate. Now the answer will be fracture reduction after 7 days. Why after 7 days? Let the swelling subside and then you do the fracture reduction, because you want perfect cosmetic fracture reduction. Nasal bone is not a functional bone, it's a cosmetic bone. So you want a perfect cosmetic reduction. For that, for assessment of the reduction, let the edema subside. So answer is wait for 7 days and then reduce the fracture. Fine. Once again, 18-year-old male was hit with cricket bat 2 days ago, and there is nasal swelling. Okay. X-ray shows what? Fracture. I'm telling you, the nasal fracture can have two type of MCQ. If there is no swelling given, immediate fracture, patient fresh fracture, and they have not mentioned any swelling, then please mark the answer immediate fracture reduction. But if they have mentioned, like in this question, nasal swelling because fracture is 2 days old, then answer is fracture reduction after 7 days. Okay. Answer of this question is C. C. The fracture reduction after 7 days. 7 days. Okay. Fine. Fine. Next one. Next one. Now, 29-year-old HIV positive individual presents to emergency in a critical state with deranged vital. The examination shows a blackish necrotic debris in the nasal cavity with the necrosed skin of the external nose. What is the best treatment of this patient? First of all, something black in the nose. Don't forget, something black in or around the nose is actually what is the mucormycosis. Is actually what? Mucormycosis. Please remember, mucormycosis, how the key word is black. Can you see the black thing? Mucormycosis. It is seen in HIV positive patient or young diabetic patient. It's a fungal infection, a very serious condition. It is typically seen in HIV positive patient or young diabetic patient. HIV positive patient or young diabetic patient. Guys, in this case, he's telling you very clearly the patient is suffering from HIV. You know, there's a HIV positivity there. Okay, there is a blackish necrotic debris with the necrosed skin of the external nose given in the picture. Okay, what is the drug of choice? M4-tyrosine B. What is the diagnosis of this patient? Is mucormycosis. Mucormycosis. Mucormycosis is the diagnosis. Okay, something black in or around the nose. The diagnosis is mucormycosis, and please do remember, mucormycosis is seen in HIV positive patient or young diabetic patient. HIV positive patient or young diabetic patient. HIV positive patient or young diabetic patient. Young diabetic patient. Let me tell you, one thing to remember. Diabetes can give two questions in ENT. If they say young diabetic, nose question, the answer is mucormycosis. If they write young diabetic, nose question, answer is mucormycosis. But if they say old diabetic, 60, 70-year-old diabetic, okay, old diabetic, ear question, then the answer is malignant otitis externa. Malignant otitis externa. What I'm trying to tell you to make your diagnosis easy in the exam. Diabetes and ENT question, young diabetic nose question, mucormycosis is the answer. Old diabetic ear question, malignant otitis externa is the answer. Okay, so these kind of hacks really work in the paper. Hacks really work in the paper, beta. Okay, fine, beta, fine, very good. I hope you're revising with me, beta. I hope you're actually able to understand that we are actually carrying out the major revision of the notes which we have after attending the classes, and we are trying to look at the notes with a clinical story in our mind. Actually, beta. Am I clear, beta? Fine. Chalo. Allow me to go forward. And this is mucormycosis, and the drug of choice for mucormycosis is M4-tyrosine B, beta. Next question, beta. Again, now CT scan of the nose and sinuses has shown the most anterior ethmoid air cell, beta. Most anterior ethmoid air cell in the axial section, beta. What the name of cell, beta? I know it's agar nasai, beta. You know, agar nasai is the answer, beta. You know, agar nasai, aage, sabse aage, A-double-G-E-R-A-double-G. A-double-G mane aage, aage, beta, na? Okay, please see, this CT is irrelevant image actually, irrelevant image. What I'm trying to tell you, don't be scared in the exam, beta. Try to see, they may have given you the clue in the statement only. Sometimes just to increase the ornamental value of the question, they add an image over there. But actually they would have given you a clue in the statement itself. And the statement says that most anterior ethmoid air cell, beta. That's all, beta. Most anterior ethmoid air cell is agar nasai, beta. So the answer of this question is agar nasai, beta. Anterior most cell is agar nasai, beta. Okay, so this image is just to really make you get confused, but the person will read the statement carefully. Most anterior ethmoid air cell, oh, agar nasai, khatam, mujhe nahi pata, I don't know where it is. Okay, however it is here, but this is the most anterior cell, beta, agar nasai. Okay, chalo. Now 26th question, beta. What is the significance of the given line in the image? Okay, please see 26th question. What is the significance of the given line in the image? Look at screen, look at screen. This is Ongren line, my bad. This is Ongren line, O-H-N-G-R-E-N. Ongren's line. Okay, Ongren line is from medial canthus to angle of mandible. From medial canthus to angle of mandible, beta. Okay, Ongren line is from medial canthus to angle of mandible. Okay, now this is used in which cancer? Answer is, this is used in carcinoma of maxillary sinus. Okay, this is used in which cancer? Carcinoma of maxillary sinus. Okay, what is the importance of Ongren line? Look at screen, beta. If a cancer is above this line, beta, this is the maxilla, no, beta? This is the maxilla, this is the maxilla. So if a cancer is above this line, it will have poor prognosis because of early orbital involvement. Okay, beta. So I repeat, this line is used in carcinoma of maxillary sinus to assess the prognosis, not for the surgery, to assess the prognosis. What's the meaning of that? Any cancer above this line will have poor prognosis. Any cancer above this line will have poor prognosis due to early orbital involvement. Any cancer above this line will have poor prognosis due to early orbital involvement. Once again, let's revise with me. Ongral line, very possible visual question, clinical question. Ongral line is from medial canthus to angle of mandible. Okay, it is used in carcinoma of the maxillary sinus to assess the prognosis. Okay, any cancer above this line will have poor prognosis. Beta. Poor prognosis. Okay, beta. Now let's see the answer, beta. Now, in this case, what is the significance of given line in the image, beta? So this is Ongren line, beta. The answer to this question is C, prognostic evaluation of carcinoma of maxillary sinus. It is not for surgery, beta, not for surgery. It's not a surgical incision, beta. It is for the prognostic evaluation of carcinoma of the maxillary sinus, beta. Am I clear, beta? Guys? So the answer of this question is C, beta. I'm clear? So please see, the answer of this question is C, beta. C. Okay, fine, bache, fine. Okay, now 27. The given two nasal features are seen in which stage of syphilis? Congenital syphilis, primary syphilis, secondary syphilis, or tertiary syphilis, beta. Now, what are two things which are seeing in the screen right now? Now, this is actually first picture is saddle nose, beta. Saddle nose is seen in syphilis, the saddle nose, and this is the septal perforation. Septal perforation of the bony septum, beta. Septal perforation of the bony septum, beta. Okay, okay, bony septum. Septal perforation of which part of septum? Bony septum, beta. Bony septum, bony septum, beta. Now these two problems, saddle nose, septal perforation, will only be seen when there is destruction of tissue in syphilis, beta. And destruction of tissue is a feature of the tertiary stage of syphilis, beta. Okay, so the answer of this question is tertiary syphilis. The given two nasal features are staying in which stage of syphilis? The tertiary syphilis. What are two features, beta? Number one is saddle nose, and number two is the septal perforation in the bony part of septum. Septal perforation in the bony part of septum, beta. Okay, guys, please let's revise with me. Septal perforation are mostly seen in the cartilaginous part. Syphilis is one disease which causes perforation of bony part. Once again, which disease causes perforation of bony part of septum? Syphilis. Now this question is an advanced question. He is asking in which stage of syphilis the perforation is seen, beta? Tertiary stage, beta. Tertiary syphilis. Okay, so saddle nose, perforation of bony part of septum are two findings seen in the tertiary stage of syphilis. Third thing is that the septal perforation are mostly seen in the cartilaginous part of septum. There is one disease which typically gives rise to septal perforation in the bony part, and the disease is syphilis. Which stage of syphilis? Tertiary syphilis. Okay, fine. Now, everybody, next one. 28 question. Sunil, 7-year-old child has presented at midnight, read the question carefully, beta, midnight to emergency with history of putting a disk battery of his father's wristwatch in his nose. Disk battery, few hours back, after just few hours back. What would be the immediate management? Put xylomethylene drops, anterior nasal packing, urgent removal of foreign body, or next day removal of the foreign body in elective operation theater. What would you be like to do over there? The answer of this question is urgent removal of foreign body. Urgent, beta, urgent. Why there's the urgency, beta? Because unfortunately, it's a disk battery. It's a disk battery, beta. Disk battery. And disk battery are alkaline battery, beta. They're alkaline battery. So they can release alkali. They may release alkali, beta. They may release alkali, and that can lead to destruction of tissue. Okay, so You cannot postpone the removal for a very, very long time, beta. You must do the urgent removal of foreign body. Don't wait for the next day for the elective operation theater to come and then remove the foreign body, because that may be very late. And this foreign body is an alkaline foreign body. It's a disc battery. It's an alkaline battery. And this can release alkali, and which can cause destruction. Imagine a child who has swallowed the disc battery, a calculator battery, or a wristwatch battery. The person has swallowed that, and the battery is stuck in the esophagus. If you don't do anything for the next few hours, this battery would release the alkali, and alkali would cause destruction, and this patient may develop esophageal perforation also. So any disc battery as a foreign body in the nose, ear, esophagus should be removed urgently, because these are alkaline batteries which can release alkali, and that can cause destruction and hence a lot of complication. So the answer of this question is urgent removal of foreign body. Please, please, please do not wait for the next day, beta. Okay, this is some urgency, because it is not something a neutral foreign body, it's a disc battery, beta. Okay, fine. Now, next question, beta. 29th. All the following are true about CSF rhinorrhea except, don't miss the word except, beta, except. All following are true about CSF rhinorrhea except cribriform plate is the commonest site of leak. Correct. The most common site of leak is cribriform plate. Number 2, the CSF is leaking from the nose. Would you do number B, immediate transnasal endoscopic surgical closure of the leak site should be done? No, wrong. This is not correct, beta. This is not correct. The treatment is conservative, beta. Treatment is conservative. You may be surprised. There is CSF leaking from the nose, but you should give, first of all, the nature to heal the defect and let the leak stop naturally. You know what? There's a fracture of the skull base, there's a fracture of cribriform plate, there's a damage to cribriform plate, and all bones try to heal by callus formation. There may be callus formation in the next few days, and the leak may stop on its own. Why you want to do surgery? So treatment is not immediate surgical closure. The treatment of choice is conservative for 7 to 10 days with bed rest and of course antibiotic. Yes, we have a worry. The patient may develop brain infection, encephalitis or meningitis. We give cover to the patient of antibiotics. But the treatment of choice is conservative in the form of bed rest and antibiotic for 7 to 10 days. Third is HRCT skull base is the best radiological investigation. Correct. And most confirmatory test is beta-2 transferrin is the most confirmatory test. That's a very, very, very important question for your paper. Beta-2 transferrin is the most confirmatory test. And HRCT skull base is the best radiological investigation. Beta. Okay, fine, beta. There are many questions. And cribriform plate is the most common site of leak. Beta. Okay, bache. Cribriform plate is the most common site of leak. So let's revise certain question about CSF rhinorrhea. Most common site of leak of CSF is cribriform plate, and the best confirmatory test, the most confirmatory test of CSF leak is beta-2 transferrin estimation. The best radiological investigation is HRCT skull base, but the treatment of choice is not surgical closure, is wait and watch, is conservative therapy for 7 to 10 days with bed rest and antibiotics, because leak may stop on its own in the next few days. If leak doesn't stop in a week time, then you can plan for surgery, but immediate surgical closure should not be done. So the answer of this question is B, beta, because he's asking except, beta, except. So answer is B, beta. This is not correct, beta. This is incorrect, beta. The treatment is conservative, beta, okay, for 7 to 10 days, okay. This question has got many other questions, beta. HRCT skull base, best radiological investigation, most confirmatory test is beta-2 transferrin estimation. Beta. Now, question number 30th, beta. 30th. Okay. Now, this is again a clinical scenario, beta. 62-year-old man comes to emergency at 4 a.m. with severe epistaxis and high blood pressure. High blood pressure, beta. Management of hypertension started, but the epistaxis could not be controlled on anterior nasal packing and posterior nasal packing. What is the next management of this patient? Ligation of external carotid artery, endoscopic ligation of sphenoparietal artery, Foley's catheter placement in the nose and inflate the bulb, or electrocauterization of little area. The answer of this question is endoscopic ligation of sphenopalatine artery. Look at the question again, beta. Guys, इतना बड़ा क्वेश्चन देख के हमारी वैसे ही आत्मा काम जाती है बेटा. तुम्हें नहीं लगता बेटा? Such when you look at such a long question, you also develop hypertension over there, beta. नहीं? But try to hold your horses over there. Try to see the main essence of question, beta. The clinical story-based question may have certain data which is irrelevant, not required to reach the right answer. But go through it. 62-year-old man comes to emergency at 4 a.m. with severe epistaxis and high blood pressure. Severe epistaxis and high blood pressure means patient is having hypertensive epistaxis. Okay, management of hypertension started, but epistaxis could not be controlled on the anterior and posterior packing. I hope you remember from the notes also, whenever the packings fail, anterior packing and posterior packing even fail, then it's a very serious epistaxis. In that case, we have to first of all go for the ligation of sphenopalatine artery. And we can do that endoscopically. And the first and foremost artery to ligate is endoscopic ligation of sphenopalatine artery. If you remember, which artery is called artery of epistaxis? The answer is sphenopalatine artery. If you remember the algorithm we made in the notes also, when the anterior and posterior nasal packing fail, the next management is endoscopic ligation of sphenopalatine artery. Do you remember? Anterior nasal packing fail, then you try the posterior nasal packing also. If both the packing fail, then you tie the artery, and the first artery to ligate is sphenopalatine artery. If you remember, this artery is also called artery of epistaxis. So this patient is suffering from hypertensive epistaxis, which is uncontrolled by packing. It's a serious epistaxis which needs a more than conventional management of epistaxis. And whenever all the packings fails, the first artery we target is sphenopalatine artery ligation, and this can be done endoscopically, guys. Guys, my humble suggestion to all of you is, please do not get scared of the long, lengthy question, beta. They're there. But if you apply your own, concepts which you gathered in all these, months, and you just apply that concept over there in that question, believe me, the answer is not far away from you. But few of us, they get scared after seeing such long question, and somewhere they lose the focus while reading the half of question. In the second half of the question, they're not even focused actually. So if you're feeling like that, I would say, look at the choices first. If you would see the next best management of the patient, so just you'll get the idea what is asking you, the management protocol. Now, so you can go back and read, but you have a minute. Try to focus on the salient keywords on the question so that you're able to, solve that question. And believe me, I'm not guaranteeing you that each and every question of the which is long question will be really very easy to tackle, but a lot of them are within your own notes and domain, and little bit of lateral clinical thinking is required, and you will reach the diagnosis over them. Okay, so have faith, have really a lot of stability at heart when you're attending the paper, beta. Okay, fine, beta, fine. So this is the end of the two sections. In the first section we did the larynx and 15 question, and the second session we did the nose and sinuses question, beta. Okay, so this is the end of the part A of the class, in which we have done few clinical scenarios of larynx, and then second part we did the nose and sinuses. Now let's start the second and the final part of the class, part B, in which we're going to take now the ear beta, and the pharynx, beta, ear and pharynx. So first of all, let's do 15 question of pharynx, and then we do 25 question of the ear also, beta. Okay, fine, ready? Don't get exhausted. Try to revise as much as you can, beta, because the purpose of this presentation is to make sure that you're able to relate to the notes once again in a clinical manner and revise the most fundamental salient things in the notes, which are very likely to come in the upcoming exam, and you're able to crack the paper, beta. Okay, fine. Okay, now first of all, a 13-year-old boy has presented with recurrent episodes of perfuse epistaxis, beta. Perfuse epistaxis, young boy, beta. Young boy epistaxis, and reddish nasal mass is seen filling the nasal cavity, and is also having the proptosis of the eye, beta. What is the possible diagnosis? Of course, angiofibroma. Angiofibroma, don't forget, beta. Young boy with the nasal bleeding is angiofibroma. No doubt about it. Certain things are keywords, beta. In any subject, you will find keyword. So young boy with the nasal bleeding is 100% angiofibroma. Young boy, nasal bleeding is 100% angiofibroma. Okay, so, and I hope you remember, angiofibroma can also extend to the eye, and that can cause proptosis. And this proptosis, if you remember, is called frog face deformity. Frog face deformity. So proptosis beta. So young boy epistaxis is 100% angiofibroma. Okay. There is involvement of the eye. The tumor can go into the orbit also, and that will lead to proptosis. And this is called frog face deformity beta. Okay, I'm clear beta? Frog face deformity. If you remember beta, angiofibroma is typically a tumor of young boys beta. It's adolescent boys, 12, 13, 14-year-old boy. It's a highly vascular tumor. So presentation is epistaxis. Perfuse epistaxis beta. Very easy question to crack. Don't get confused. A young boy with epistaxis is 100% angiofibroma. And when I'm saying it with a lot of accountability, a lot of, responsibility at my end. I know the things can go wrong, but, certain things are very, very, very commonly asked actually. And people start overthinking and they create confusion. Young boy, epistaxis, nasal mass, it's angiofibroma beta. Yes, and it can extend to orbit and that can cause proptosis. Proptosis when the eye comes out, and that proptosis is called frog face deformity. Very good beta. Now, next question. 32 question, 30-second question beta. While surgical removal of impacted fish bone, the surgeon has accidentally injured internal laryngeal nerve. The surgeon has accidentally injured internal laryngeal nerve beta. Somebody is eating fish, somebody from Bengal, hilsa. It's very difficult to eat. It's very tasty fish, but you have to have practice. We North Indian, we don't have that practice to eat, hilsa. If you're eating hilsa, there's a lot of, bones, fish bones, and one of the fish bone got stuck down in the throat. And when the surgeon was removing it, the surgeon accidentally damaged one nerve, internal laryngeal nerve. And he's asking indirect anatomy. What is the possible site of impaction of fish bone? The answer of this question is piriform sinus beta. Piriform sinus is the neighbor of supraglottis of larynx beta. Do you remember piriform sinus beta? Piriform answer is piriform sinus. But look at screen beta. The answer is piriform sinus. Piriform sinus beta. Piriform sinus beta. Am I clear? Look at screen beta. If you remember, this is your supraglottis of larynx. This is what beta? Supraglottis. Supraglottis is what? Supraglottis. Supraglottis of larynx beta. Hai. This is supraglottis of larynx. Okay. And these arrows represent what? Piriform sinus, piriform sinus, piriform sinus beta. Piriform sinus is a part of laryngopharynx beta. Piriform sinus is a part of laryngopharynx. Okay. Guys, this is larynx. Larynx. This is laryngopharynx, the food tract, laryngopharynx. Okay, laryngopharynx has got, one part piriform sinus right, piriform sinus left. Now, what happens is, please see on the screen, this is your, again, supraglottis, which is the part of the larynx. This is what, piriform sinus. You remember food tract, Can you see saliva over there, The saliva indicates it's the food tract, Saliva indicates food tract, Can you see piriform sinus? Okay. Now, please understand that these two areas are supplied by single nerve beta. The sensory spline. Now, look at screen beta. The internal branch of superior laryngeal nerve, also called as internal laryngeal nerve, it gives sensory supply to supraglottis and piriform sinus. Again, everybody revise with me, beta. The purpose of this class is to make you revise a certain clinical concepts which can be related to anatomy and can be asked indirectly, beta. So let's revise, beta. Internal branch of superior laryngeal nerve, also called as internal laryngeal nerve, it gives sensory supply to number one, supraglottis, and number two, piriform sinus. Supraglottis and number two, piriform sinus, beta. Okay. Okay. So internal branch of superior laryngeal nerve is also called as internal laryngeal nerve. It gives sensory supply to number one, supraglottis, and number two, piriform sinus, beta. Okay. Now look at screen, beta. Look at screen, everyone. Please see. This is your supraglottis, piriform sinus. Okay. Again, this is your supraglottis. This is your piriform sinus, beta. Okay. Fine, beta. Now please see on the screen, beta. This is a nerve coming, beta. The internal branch of SLN, beta. In the. Okay. It gives sensory supply to supraglottis, beta. Okay. And one of its branch gives sensory supply to piriform sinus also. This is the internal branch of the superior laryngeal nerve, beta. Can you see their neighbor, beta? The same nerve gives supplies to supraglottis. The same nerve gives sensory supply to piriform sinus. What is it? Piriform sinus, beta. Okay, beta. Fine. Now read the question carefully again. While surgical removal of impacted fish bone, the surgeon has accidentally injured the internal laryngeal nerve. Internal laryngeal nerve has got injured, beta. What is the possible site of impaction of foreign body? The answer is piriform sinus. Come on, clear, beta? Piriform sinus. Is it clear to all? Clear to all, beta? Fine. Okay. Now, let's do further. Okay. Now, next question, beta. 52-year adult patient, 52-year adult patient presenting with right-sided hearing loss. Oh, hearing loss patient has been subjected to audiological investigations and diagnosed to be a case of right-sided serous otitis media. Right-sided serous otitis media. What would be the priority in management? Priority in the management of the patient, beta. First of all, don't forget, this serous otitis media is other name of glue ear. It's only on the right side, beta. Right side. It's only on the right side, beta. It's only on the right side. Am I clear, beta? Right side. Okay. Now, guys, one rule I want you to remember, beta. This can be a very possible question in your paper. Please understand. Adult patient with unilateral glue ear can be due to nasopharyngeal carcinoma. Nasopharyngeal carcinoma, NPC. I repeat, beta. Adult patient with unilateral glue ear. The cause can be NPC. What is NPC? Nasopharyngeal carcinoma. Okay, beta. Now, if you remember, nasopharyngeal carcinoma, let me show you that place, beta. Please see. Yes. Now, this is your nasopharynx, beta. Okay. This is your eustachian tube opening. This one. Now, this arrow is called FOR. Another question about FOR. What is FOR? Fossa of Rosenmuller. This can be your visual question again, beta. Fossa of Rosenmuller, beta. Fossa of Rosenmuller is just above the eustachian tube opening, beta. It is the most common site of origin of nasopharyngeal carcinoma. It is the most common site of nasopharyngeal carcinoma, beta. Look at beta. This is your eustachian tube. It's connecting the middle ear to the nasopharynx. This is the middle ear, beta. This is eustachian tube. Okay. And this is opening over here, beta. This is opening of the tube, beta. Okay. Now, if there is a cancer over here, beta, please see. Imagine there is a cancer over here, beta. The cancer start over here, beta. The cancer over here, beta. The nasopharyngeal carcinoma is the most common site of origin is fossa of Rosenmuller, beta. Now, within few weeks, it will cover the eustachian tube opening, beta. It will block the eustachian tube opening. Due to that, what will happen is in the middle ear, there will be collection of thick glue-like fluid in the middle ear because the drainage got stopped, beta. The drainage is stopped now. So this condition is called glue ear, and it's only on the one side, beta, unilateral. Can you see it's only on the one side, beta? Other side is normal. It's only on the one side, glue ear. Okay, and this will lead to conductive hearing loss, beta. CHL means conductive hearing loss. Okay, beta, fine. So what I'm trying to tell you, the adult patient developing unilateral conductive hearing loss or unilateral glue ear is something serious, beta. Adult patient with the unilateral glue ear, the cause may be NPC, matlab nasopharyngeal carcinoma. So in this patient, please do not manage glue ear. Cancer is a big problem. First of all, rule out cancer, beta. That's what he's asking. He's saying that what will be the priority in the management of the patient. Priority, not glue ear is not a priority. Priority is nasopharyngoscopy and biopsy. Why? To rule out nasopharyngeal carcinoma. Okay, once again, beta, adult patient with unilateral right side serous otitis media माने glue ear बेटा. Adult patient with the unilateral glue ear, the most likely possibility to be ruled out is nasopharyngeal carcinoma. So in this case, my priority of management is not focusing on the glue ear like grommet insertion and all that. My priority is to rule out nasopharyngeal carcinoma. So I'll be doing nasopharyngoscopy and biopsy. Nasopharyngoscopy and biopsy. Okay, fine. Okay, fine. Done. Chalo. Now, a 23-year-old patient has developed chin swelling. The moment you see chin swelling with trismus following right lower last molar infection. After dental infection, chin swelling. Can you see chin swelling here? Chin swelling. Now this is due to Ludwig's angina. The diagnosis of this case is Ludwig's angina. Very important question, beta. Ludwig's angina. It is the infection of floor of mouth, beta. Ludwig's angina is what? Infection of floor of mouth, beta. Okay, please see, this is your mandible, beta. In the mandible, you have got molar, premolar, and all that. In one of the molar, the patient got some caries, and that infection came to this root and made an abscess over there, beta. Okay, beta. So basically, in Ludwig's angina, the chin swelling happens after dental infection. The chin swelling happening after dental infection is Ludwig's angina, beta. Very simple question to crack. Once again, please read. Please read, beta. A patient 23-year-old has developed the chin swelling with the trismus. Chin swelling with the trismus after dental infection, beta. Okay. Following right lower last molar infection. What is the possible diagnosis? Ludwig's angina. It's not a cardiac problem, beta. Angina is not cardiac here. It's only word used for pain. Okay, Ludwig's angina has got nothing to do with the heart, beta. Ludwig's angina, it's the infection of floor of mouth, which is secondary to some dental infection. The typical history is after dental infection, patient develop chin swelling and trismus, beta. Okay, now let's go further, beta. 35th. Now you know it. Identify the anatomical area marked with the arrow. Yes, it is what? Piriform sinus, my dear friend. This is piriform sinus. This is also piriform. If you ever get this kind of question in the exam, they can ask you, they can show you on the side of larynx. If you see an area marked with arrow, there is piriform sinus right and piriform sinus left. There are two piriform sinus. So answer is piriform sinus. Okay, piriform sinus. Fine. On the side of larynx, if you ever see some space like that marked with arrow, the answer is piriform sinus. Okay, fine. Now, so answer is what? Piriform sinus. Very good. Now please see, this is what, beta? Piriform sinus. Piriform sinus. Okay, beta? Fine. Chalo. Now another question. Identify the anatomical area marked with the arrow. I hope you know now. We just did that. This is Eustachian tube opening. This is what, beta? Fossa of Rosenmuller. Yes, fossa of Rosenmuller, beta. Okay, beta. Can you see that, beta? Fossa of Rosenmuller lies just above Eustachian tube opening, beta. What is the name of this fossa? Fossa of Rosenmuller, beta. Don't forget, beta. There can be two visual questions, beta. One is opening shown like this, beta. Eustachian tube opening. And they can ask you, what is this fossa called? Fossa of Rosenmuller. And please do remember, what is the importance of fossa Rosenmuller? It is the most common site of development of nasopharyngeal carcinoma. Once again, fossa of Rosenmuller is the commonest site of origin of nasopharyngeal carcinoma, NPC. Start from here, better, nasopharyngeal carcinoma. And any arrow they show like this, when they ask you on the side of larynx, what is this arrow suggesting or showing in the anatomy? Piriform sinus, beta. On the side of vocal cord, if you see an arrow, piriform sinus, beta. And on above the Eustachian tube, if you see an arrow, that arrow indicates what? Fossa of Rosenmuller, beta. Am I clear, beta? Fossa of Rosenmuller, beta. Everybody look at screen, beta. Let me clean this picture for you. This can be your question, visual question, anatomy, clinical, asked and all that, beta. Am I clear, beta? Fine, everybody. Okay, please see. Okay. So everybody's clear, beta? Everybody's clear. This is the fossa of Rosenmuller. This is a site of origin of nasopharyngeal carcinoma. Okay. What is this opening? Eustachian tube opening, beta. Okay. Can we go further? Now, what is the commonest presentation of nasopharyngeal carcinoma, beta? NPC. Nasopharyngeal carcinoma. The commonest presentation of nasopharyngeal carcinoma is cervical lymphadenopathy. Beta. Guys, nasopharyngeal carcinoma is a very important topic. Beta. Okay. So what is the commonest presentation of nasopharyngeal carcinoma is cervical lymphadenopathy. Beta. Cervical lymphadenopathy. Cervical lymphadenopathy. Okay. And what do you mean by that? Is equal to metastatic neck node. Metastatic neck node. Guys, let me go NPC. N. Start from N now. The first finding will be N money neck. Remember, neck has to be the commonest presentation will be something in the neck. NPC, nasopharyngeal carcinoma, start from N. The commonest presentation will start in the N. What is N? Neck. So it can be written cervical lymphadenopathy or metastatic neck node. Okay. So this is the answer. Cervical lymphadenopathy, and the patient would be having neck nodes. Can you see? The cancer has already metastasized from here to the neck nodes. Can you see? Okay, so the most common presentation of nasopharyngeal carcinoma, NPC, is something in the neck, N money neck, neck. Will you remember, beta? The commonest presentation of NPC is neck node, cervical lymphadenopathy, or metastatic neck node. That can be answered, beta. Okay, fine. Now, next one. Again, don't get scared of looking at such long questions. They're easy. Just only thing you have to apply your notes properly. 17-year-old male patient underwent tonsillectomy on Monday, the first day of the week, Monday. The person got a surgery done on the day 1. This is Monday is the day 1. Post-operative period was normal. Discharged the next day. Tuesday he went home. Sunday morning, 6th day, he has presented to emergency department of the hospital with the complaint of mild bleeding from oral cavity. Mild bleeding from oral cavity. What is the best management? First of all, it is a case of complication of tonsillectomy. Now, it's a case of secondary hemorrhage after tonsillectomy. Because the surgery happened on Monday. Okay, the problem happened on Sunday. After 6th day, 6th day, na? Okay? So there are basically hemorrhages in tonsillectomy. Let's revise, beta. Hemorrhages in tonsillectomy are of 3 types. Number 1, primary hemorrhage. The primary hemorrhage is during surgery. What we're revising, hemorrhage in tonsillectomy are of 3 types. Hemorrhage in tonsillectomy are of 3 types. Primary hemorrhage is during surgery. Number 2. Reactionary hemorrhage is within 24 hours of surgery. Within 24 hours of surgery. Now, this is due to slippage of ligature. You must have put a stitch to close the bleeding from an artery or vein. That stitch came out. Third point, it's an emergency. Never forget, reactionary hemorrhage can kill the child, beta. This is an emergency. Because a lot of bleeding, patient is puking blood, vomiting blood, beta. And the treatment is re-exploration. The treatment is re-exploration, beta. That's MCQ, beta. How to remember, beta? RE reactionary, RE re-explore, beta. That's MCQ. The treatment of reactionary hemorrhage is re-exploration. Okay. Now, number 3, beta, secondary hemorrhage. Beta. Don't forget, beta. Number 3, secondary hemorrhage. Beta. Primary, reactionary, secondary. Secondary hemorrhage is after 5th day of surgery. Beta. After 5th day of surgery. After 5th day of surgery. Okay. It is due to infection. It is due to infection. But it is mild bleeding. Little bit of bleeding, but it is due to infection. So the treatment is admit the patient again and IV antibiotics. Main thing is IV antibiotics. Don't do any re-exploration, only IV antibiotic. IV antibiotics. IV antibiotic. Let's revise once again, beta. Let's revise once again that there are 3 types of hemorrhage during tonsillectomy or after tonsillectomy. Number 1, primary hemorrhage during surgery. Number 2, reactionary hemorrhage within 24 hours of surgery. It is due to slippage of ligature. ligation wala stitch, that stitch came out, it's an emergency because patient is puking blood now. The treatment is re-exploration. How to remember? RE reactionary, RE re-explore beta. Number 3, secondary. Secondary hemorrhage is after 5th day of surgery. It is due to infection. It is mild bleeding. So treatment is IV antibiotic. Don't do anything. Admit the patient and start IV antibiotic beta. Okay. Now look at this question beta, which you got just now. Once again, look at the question, everybody. Now, 17-year-old male patient underwent tonsillectomy on Monday. On Sunday morning, he presented to emergency with mild bleeding beta, Sunday. So Monday, one day, 6th day beta, Sunday. Any hemorrhage after 5th day. Monday the surgery did, Sunday. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. 6th day bleeding happens beta. This is a case of secondary hemorrhage. This is a case of secondary hemorrhage beta. Okay. So treatment is admission and antibiotics beta. Do not re-explore beta. Re-exploration is not done for reactionary. Re-exploration is done for reactionary hemorrhage beta. Reactionary re-explore. But this is a case of secondary hemorrhage. Once again, read beta. 17-year-old male patient underwent tonsillectomy on Monday. Post-op was uneventful. Sunday morning, he came back. On 6th day, he came back to the emergency with mild bleeding from mouth. This is the case of secondary hemorrhage. And secondary hemorrhage, we give intravenous antibiotic. Admission, yes, admit the patient and just give IV antibiotic. Okay? Okay, IV antibiotic. Do not re-explore. Re-exploration is the treatment for reactionary hemorrhage. RE reactionary, RE re-explore. Okay, let's go next one. 39th question. All the following are true about nasopharyngeal carcinoma, Trotter's triad, except. Trotter's triad is important question in nasopharyngeal carcinoma, except. Let's revise beta. Okay, please see Trotter's triad. Let's revise beta. Trotter's triad in nasopharyngeal carcinoma. Trotter's triad. How to remember the NPC is a nasopharyngeal carcinoma. And fortunately, the mnemonic of Trotter's triad is also NPC. What is N? Neuralgic pain in temporoparietal area. What is P? Palatal palsy. What is C? Conductive hearing loss, unilateral due to glue ear. Let's revise once again, beta. Trotter's triad is seen in nasopharyngeal carcinoma, NPC. The mnemonic of Trotter's triad is also NPC. N mane neuralgic pain in temporoparietal area. P mane palatal palsy. C mane conductive hearing loss. Conductive hearing loss, unilateral due to glue ear. Glue ear. Hai na? Okay. Once again, Trotter's triad is seen in nasopharyngeal carcinoma. Number 1, N, neuralgic pain in temporoparietal area. Number 2, P, palatal palsy. Number 3, conductive hearing loss due to glue ear. Okay. So, which of the following is not a feature of Trotter's triad? Is a very clear-cut answer for you. The answer of this question is sensory neural hearing loss. That's not a feature. Not a feature, beta. All other except, beta. Except. Don't miss the word except, beta. Except. P, N, C, beta. Hai na, beta? Fine. But it's not SNHL. It is conductive hearing loss, beta. Okay, bache. Now, one more question over here. The treatment of nasopharyngeal carcinoma is chemoradiation, beta. Very commonly asked question. What is the best treatment for nasopharyngeal carcinoma? The best answer is chemoradiation, beta. If chemoradiation is not given the choice, then the answer is radiotherapy. Radiotherapy, beta. So treatment of nasopharyngeal carcinoma is the best answer of nasopharyngeal carcinoma treatment is chemoradiation. If that is not given the choice, then radiotherapy is the second best answer. Radiotherapy is the second best answer. Am I clear, bache? Fine. Okay. Now, 40th question. A patient with sore throat, fever, cervical lymphadenopathy, and oropharyngeal picture given in the image. What is the possible diagnosis, beta? Pediatric question also, beta. Can you see the oropharyngeal picture, beta? Please see on the screen, beta. Oh, this any whitish membrane going beyond tonsil to palate. In the background of history of patient with fever, neck node, that suggests diphtheria. Diphtheria. Guys, diphtheria membrane extends beyond the tonsil to the palate. Okay. Now read the question carefully again. Other symptoms also support diphtheria, like sore throat, fever, cervical lymph adenopathy. If you remember pediatric, PSM pediatric, diphtheria gives to bull neck, bull neck. Bull neck. Diphtheria gives to bull neck. Bull neck means cervical lymph adenopathy on both sides. And in the oropharynx, the membrane of the diphtheria extends beyond tonsil to the palate. And so the answer of this question is diphtheric tonsillitis. Okay, fine. So membrane of diphtheria extends beyond tonsil to the palate. Okay, fine. Okay, bacha, fine. Now, next question, beta. Next one. Oropharyngeal picture of a patient with the trismus, plummy voice, dysphagia. Trismus, plummy voice, dysphagia, and the picture given over here is this one, beta. What are two things you're seeing in this picture are? Number one you're seeing is over here that uvula is pushed to the other side. Tonsil is pushed to the other side. Uvula pushed to other side, tonsil pushed medially. The diagnosis of this patient is quinsy, also called as peritonsillar abscess. Peritonsillar abscess. Why? There's a collection of pus between tonsil and its bed. There's a lot of pus over here. What is the name of the abscess? Quinsy, also called as peritonsillar abscess. Peritonsillar abscess. It is a collection of pus between tonsil and its bed. This pus is pushing the tonsil and uvula on the other side. Am I clear? Pus is pushing the tonsil and uvula on the other side. Okay. Now the characteristic finding. Uvula teda hai. So quinsy is the answer. Quinsy. Please understand. Please think this is a very common question asked actually in various papers. It is repeated off and on. Expected to come. In some of the exam like that. Please understand. The key word in this question is that trismus. Number two, plummy voice. If you know, plummy voice is other name of hot potato voice. Hot potato voice. Okay. And dysphagia. What is the characteristic picture on the examination? Teda uvula. Uvula is angulated. Teda. Uvula teda. Quinsy. Uvula is little angulated. Okay. And tonsil is also pushed medially. So the answer of this question is quinsy. Quinsy. Okay. But if same question, everything, same question, same image, same history, plus outer neck swelling. Outer neck swelling close to angle of mandible. Same question, same history, same examination, same symptom, everything damn same. Only one difference is that there is also one more extra finding that outer neck swelling close to angle of mandible is given. Then the answer will change to parapharyngeal abscess. Parapharyngeal abscess. Let me tell you, quinsy and parapharyngeal abscess are 99% same MCQs. Same history, trismus, yes, trismus. Hot potato voice, yes, hot potato voice. Dysphagia, yes, both sides. Uvula pushed to other side, yes, both side. Tonsil pushed medially, yes, both side. But in quinsy, there is never a mention of outer neck swelling. But if same question of history of examination of quinsy is given, along with that, one more thing is given over there. There is outer neck swelling close to angle of mandible. Rest everything is same like this question. Then the answer will change to parapharyngeal abscess. Once again, quinsy and parapharyngeal abscess are 99% same questions. Same history, same examination, same uvula pushed to other side, same tonsil pushed to other side. Only one difference is in quinsy, there is no outer neck swelling. In parapharyngeal abscess, there is outer neck swelling close to angle of mandible. So guys, never get confused in the paper. If you see everything written like this, but there is no mention of neck swelling from outside neck swelling, then it's quinsy. But if there's a mention of outside neck swelling, same finding, same history, same examination finding, then please mark parapharyngeal abscess. Am I clear, beta? Fine. Now, everybody, 42nd question, beta. Anatomy and clinic also. What is the exact anatomical site of formation of Zenker's diverticulum or pharyngeal pouch, beta? What is the exact anatomical site of formation of Zenker's diverticulum or pharyngeal pouch? Beta? Let me tell you, beta. Please see. Pharynx has got three muscles. If you remember, this is your pharynx, beta. This is your base of skull. This is your skull base. Okay. This is your pharynx, beta. This is your pharynx. If you remember, your pharynx has got three muscles. The first muscle is called superior constrictor. Okay. The second muscle is called the middle constrictor. Middle constrictor. Okay. The third muscle, the inferior constrictor, has got two type of fibers. One is the oblique fibers, and the other one are circular fiber. In between the two, there's a triangular area where you have got no muscle over there. Okay. Now this is called thyropharyngeus. This is called cricopharyngeus. Thyropharyngeus, and this is called cricopharyngeus. Circular, na? Thyropharyngeus are oblique fibers. Cricopharyngeus are circular fiber. Okay. Now please see, thyropharyngeus plus cricopharyngeus is inferior constrictor. Inferior constrictor is made of two muscles, beta. Thyropharyngeus are oblique fibers. Cricopharyngeus are circular fiber. Now there is a triangular area between the two. That area doesn't have any muscle. This area is called Killian's dehiscence. So one question, Killian dehiscence is between which two muscles? Killian dehiscence is in the inferior constrictor muscle between the thyropharyngeus and cricopharyngeus. Inferior constrictor muscle has got two parts. The oblique part is called thyropharyngeus. The circular part is called cricopharyngeus. Between the thyropharyngeus and cricopharyngeus, there's a triangular area, which is a weak area because it doesn't have any muscular layer, and it is called Killian's dehiscence. Okay. Now, Killian's dehiscence means a weak area, beta. So it is a very common site of formation of pharyngeal pouch, beta. You know, pharynx mucosa. Pharynx mucosa can herniate out like this and can pouch out like this. Now this is called Zenker's diverticulum or pharyngeal pouch, or pharyngeal pouch. Zenker's diverticulum or pharyngeal pouch. This weak area, Killian dehiscence, is the site of formation of Zenker's diverticulum or pharyngeal pouch. Once again, beta, the inferior constrictor muscle has got two type of fiber. The thyropharyngeus are the oblique fibers. Cricopharyngeus are the circular fibers. Between the two, there's an area called Killian's dehiscence, and that Killian dehiscence is lying in which muscle? Inferior constrictor muscle. Between two muscles, thyropharyngeus and cricopharyngeus. So Zenker diverticulum also forms at the Killian dehiscence. So it means that this question answer, look at screen, what is the exact anatomical site of formation of Zenker diverticulum or pharyngeal pouch? It is between thyropharyngeus and cricopharyngeus. Don't forget, beta, thyropharyngeus plus cricopharyngeus is equal to inferior constrictor, beta. Okay, beta. So this can be asked like this also. Where lies the Killian dehiscence, beta? So Killian dehiscence is also between the thyropharyngeus and cricopharyngeus, beta. These two are the parts of inferior constrictor muscle, beta. So the answer to this question is C. The exact site of formation of Zenker diverticulum or pharyngeal pouch is between thyropharyngeus and cricopharyngeus. Once again, beta, look at screen, beta. The pharynx has got three muscles: superior constrictor, middle constrictor, inferior constrictor. Inferior constrictor has got two parts, thyropharyngeus and cricopharyngeus. Between the thyropharyngeus and cricopharyngeus, there is a triangular area which doesn't have any muscle, and that area is called Killian's dehiscence, and that is the site of formation of Zenker's diverticulum, beta. That is site of formation of Zenker diverticulum, which is also called pharyngeal pouch. Am I clear, beta? Fine. Okay. Now, next one. What is the best treatment for reactionary hemorrhage? Do you remember, beta? RE reactionary. RE re-explore, beta. Remember? Reactionary re-explore. This is the answer, beta. Reactionary hemorrhage re-exploration. Beta. Reactionary hemorrhage within 24 hours, beta. So RE reactionary, RE re-explore, beta. Reactionary hemorrhage is a very serious condition. So treatment is immediate re-exploration. Now, next one is 44. A young child operated for adenotonsillectomy has developed atlantoaxial subluxation. What is atlantoaxial subluxation? Is C1, C2. Okay, C1, C2, beta. C1, C2 subluxation. What is the possible diagnosis, beta? Please see. During adenotonsillectomy, we use a position of the patient called rose position. And rose position is actually having mainly neck extension. Neck extension. During adenotonsillectomy, the position of patient is called a rose position. In that position, there is a lot of neck extension, but over extension of neck can lead to atlantoaxial subluxation. And what is the possible diagnosis in this case is Grissel syndrome. And that is Grissel syndrome. What is the possible diagnosis in this case is Grissel syndrome. GRISL Grissel syndrome. Once again, beta, during adenotonsillectomy, we use a position of the patient called rose position. Look at me. It is actually mainly neck extension. Over extension of neck of the child can lead to atlantoaxial subluxation. Means C1, C2 subluxation. And that complication of the surgery is called Grissel syndrome. So the answer of this question is Grissel syndrome. Grissel syndrome, beta. Okay, fine, beta. Grissel. Atlantoaxial subluxation. C1, C2 subluxation, beta. Okay. Now everyone, please see beta. Now let's go further. Can we go further, beta? Yes. Next question, beta, everyone, please see. Yes. 45th question. Which virus is implicated in the nasopharyngeal carcinoma? Which virus is implicated in nasopharyngeal carcinoma? Which one is EB virus? Very good, beta. Epstein-Barr virus is responsible for nasopharyngeal carcinoma. So NPC, which virus is EBV? Beta. Nasopharyngeal carcinoma is important topic, beta. Nasopharyngeal carcinoma, which virus is implicated is Epstein-Barr virus, beta. Okay, beta, fine. So these were the 15 questions of the pharynx, beta. We have done 15 questions of the larynx, 15 of nose, and now 15 of pharynx in this session, beta. Okay. Now the last part of the session is ear question, and now we're going to do 25 questions of ear, beta. In the last part, we'll be doing 25 questions of ear. Okay. Now let's start, beta. Now everybody look at screen, beta. Now, blood-stained, foul-smelling, chronic ear discharge with otoscopy finding given in the image, what is the possible diagnosis in the patient, beta? Okay, please first of all, get it very clear, beta. Blood-stained, foul-smelling, chronic ear discharge. This is indicative of cholesteatoma. And I hope you remember, the presence of cholesteatoma is called unsafe CSOM. C means chronic. Unsafe means risky. Unsafe CSOM, beta. Unsafe CSOM. So whenever you see a question in the paper with the history written as blood-stained, foul-smelling ear discharge, then think about the possibility of cholesteatoma. So cholesteatoma, which is actually the unsafe CSOM, the typical history is blood-stained, foul-smelling ear discharge. So, imbibe the keyword, blood-stained, foul-smelling ear discharge, we should think of cholesteatoma, and presence of cholesteatoma is called unsafe CSOM. Okay. Now, please understand, beta. Now, cholesteatoma has got multiple type of origin. Now, the most common origin is the primary acquired cholesteatoma. Please don't forget this picture, beta. Now, cholesteatoma is pearly white in color. Can you see, beta? This is look of the cholesteatoma, and cholesteatoma is pearly white in color. Now, this is cholesteatoma, beta. My dear friends, this is cholesteatoma. Okay. I hope remember this part of tympanic membrane is called pars tensa, and the upper part of the tympanic membrane is called pars, PARS, pars flaccida. Okay, guys. Now let me tell you a clue to remember for the exam. Any cholesteatoma in the upper part of tympanic membrane or in the pars flaccida of tympanic membrane is called primary acquired cholesteatoma. If any time you get a question in the paper and they show you a pearly white mass in the upper part of tympanic membrane, please don't get confused. Just mark primary acquired cholesteatoma, because primary acquired cholesteatoma are due to retraction pockets, and retraction pocket are most commonly seen in the pars flaccida. If you don't want to go into detail of like all this, please do remember this picture, a very possible question. Blood-stained, foul-smelling ear discharge indicates cholesteatoma. Presence of cholesteatoma is called unsafe CSOM. The most common site of cholesteatoma is the upper part of middle ear. Color of cholesteatoma is pearly white. And whenever they show you a pearly white mass in the upper part of tympanic membrane. Whenever they show you the pearly white mass in the upper part of tympanic membrane like this, please mark it is primary acquired cholesteatoma. This is primary acquired cholesteatoma. This is called primary acquired cholesteatoma. Am I clear, beta? Primary acquired cholesteatoma, beta. Okay. So this is your, I would say, the blood stain, foul smelling, chronic ear discharge with otoscopy finding given the image. So please remember, pearly white mass is cholestoma. If cholestoma is in the upper part of the tympanic membrane, it's primary acquired cholestoma, beta. Okay, beta? Fine. Okay. Now there's another cholestoma which can be congenital, beta. Congenital. How to find this one, beta? This is also pearly white, beta. Can you see pearly white mass? This one, beta. You see this one. Pearly white mass behind intact tympanic membrane. The keyword is intact. Behind intact tympanic membrane. Pearly white mass behind intact tympanic membrane is congenital cholestoma. If the tympanic membrane is intact, means it has the cholestoma, the skin has not gone from outside. It has been there since birth. If you get a question like this, beta, once again, pearly white mass behind intact tympanic membrane is congenital cholestoma. But pearly white mass in the upper part of tympanic membrane, like this, is primary acquired cholestoma. I repeat, beta, pearly white mass is cholestoma. If you see pearly white mass in the upper part of tympanic membrane, please mark the primary acquired cholestoma. But if you see the pearly white mass but behind intact tympanic membrane, then it is congenital cholestoma. Matlab, it has not gone from outside, it has been there since birth, means congenital cholestoma. So pearly white mass behind intact tympanic membrane, congenital cholestoma. Congenital cholestoma. Okay, next question. Next question. A congenitally deaf child, deaf child. And what diagnosis with the bilateral profound SNHL? Profound means too much. Deaf means almost hearing is zero. Profound SNHL. On radiological evaluation has been found to have intact eighth nerve on both sides. Intact eighth nerve on both sides. What is the best method of hearing rehabilitation in this case? The answer is cochlear implant. Cochlear implant. Guys, don't forget this case, this scenario, beta. Deaf child, technically it is called bilateral profound sensory neural hearing loss. Beta. Okay. Guys, cochlear implant. When you put an implant in the cochlea, the electrode in the cochlea, there is one indication of surgery. What is the indication of this surgery? Is bilateral profound SNHL. Okay. Now, what is the pre-condition of surgery? The first one is indication of surgery. Second is pre-condition of surgery is normal eighth nerve. Normal eighth nerve. Normal eighth nerve. The indication of surgery is bilateral profound SNHL. Precondition of surgery is normal eighth nerve. Normal eighth nerve. Am I clear? Normal eighth nerve. Done, bache? Now, look at this question, beta. This patient has got both the thing, beta. Patient is suffering from bilateral profound SNHL, eighth nerve normal on both sides, and patient is a deaf child. A deaf child would need your support, beta. Would need some surgery to restore the hearing. And what is the best method of hearing rehabilitation in this case? Answer is cochlear implant. Once again, whenever you see in an MCQ, don't be a scientist on that day, beta. Just don't dissect the question too much and spoil the answer. There are certain clear things, beta. Bilateral profound SNHL with normal eighth nerve, cochlear implant is the answer, beta. Bilateral profound SNHL with the normal eighth nerve, the answer of the procedure is cochlear implant, beta. Let's not create too much confusion in the paper. Let's stick to the basic fundamental things. Bilateral profound SNHL with the normal eighth nerve, the answer is cochlear implant, beta. Okay, fine. Now, next question, beta. A patient, this is a very important question. This is a very star question, beta. Let me tell you, this can come. A patient of right unsafe CSM has presented with double vision diplopia and pain behind the right eye. What is the name of this entity? The name of this entity is Grady-Nigo syndrome. Grady-Nigo syndrome. Do you remember Grady-Nigo syndrome? Grady-Nigo syndrome is also called as petrositis. Okay, beta. Grady-Nigo syndrome is also called as petrositis, beta. Okay, petrositis. If you remember, there is a petrous bone and there can be infection of that bone, and that is called petrositis, beta. Grady-Nigo syndrome, beta. How to remember Grady-Nigo syndrome? Grady-Nigo syndrome has a triad, beta. Triad. Let's revise the triad. Grady-Nigo syndrome has a triad. Triad. How to remember, beta? G is the name over here, na? E R D. Triad. Three feature, beta. First feature is ear discharge. Have you heard the word GERD, beta? Gastroesophageal reflux disease, beta. E mane ear discharge. R mane retroorbital pain. D mane diplopia. Remember GERD, beta. The mnemonic is GERD. Grady-Nigo syndrome, which is other name of petrositis. It has got a triad of features: ear discharge, retroorbital pain, and diplopia. Okay, beta. Grady-Nigo syndrome, it has got ear discharge, retroorbital pain, and diplopia. GERD. Okay. Okay, beta. Look at the question, beta. Once again, double vision, diplopia. Pain behind the right eye, retroorbital pain, beta. Okay. So, okay. And this is actually patient is suffering from Grady-Nigo syndrome, beta. Some people would have confused with Gressinger sign, beta. Let me clarify. Gressinger sign and Grady-Nigo may be overlapping word, beta. Gressinger sign is seen in sigmoid sinus thrombosis. Okay. Now, what is it? It is pitting edema on mastoid, beta. It is seen in sigmoid sinus thrombosis. It is actually pitting edema over mastoid, beta. Okay, beta. Pitting edema over mastoid, beta. Okay, so Grady-Nigo syndrome can sometimes be confused with Gressinger sign, but they're different. Grady-Nigo syndrome is a triad actually. GERD, Grady-Nigo. E mane ear discharge, retroorbital pain, diplopia. But Gressinger sign is seen in sigmoid sinus thrombosis. It is pitting edema over mastoid, beta. Pitting edema over mastoid. Am I clear, beta? So don't forget this question, beta. This is a clinical scenario-based question. A patient with CSOM developed the pain behind the right eye. Double vision. What the name of entity? Grady-Nigo syndrome. Answer is Grady-Nigo. C, beta. That's the correct answer. Grady-Nigo syndrome, beta. Okay. Once again, beta. Grady-Nigo syndrome has got three features. GERD. E mane ear discharge. R mane retroorbital pain, and D mane diplopia. But Gressinger sign is pitting edema on the mastoid. It's a feature of sigmoid sinus thrombosis. Okay. Now, identify the maneuver given in the image. This is a possible visual question in your paper. Identify the maneuver given in the image. The answer is Dick-Solpike maneuver. Dick-Solpike maneuver has two images. Two images. Look at screen. Dick-Solpike maneuver. It is a diagnostic test of BPPV. It is a diagnostic test of BPPV. It has got two images. In the first image, the patient is sitting, and then suddenly you make the patient lying down. So Dick-Solpike maneuver is a diagnostic test of BPPV. What is full form of BPPV? Benign paroxysmal positional vertigo. Very important topic, beta. Benign paroxysmal positional vertigo. So Dick-Solpike maneuver has got two images, beta. One of sitting, other of lying down, beta. It's a test of BPPV to diagnose the BPPV. So let's revise once again. Dick-Solpike maneuver is a diagnostic test of BPPV. It has got two images, beta. But you can get this image also, beta, in the paper. Now this is Apple's maneuver, beta. This is Apple's maneuver. It has got five images, beta. If you get something like five images, beta, this is number one, sitting, then lying down, number two, then take a head turn, number three, then take a body turn, number four, and number five, again sit up, beta. From sitting to sitting, five positions, if they make, then it is Apple's maneuver. Apple's maneuver is treatment of BPPV, beta. Apple's maneuver is treatment of BPPV. Apple's maneuver is treatment of BPPV, beta. Beta. Apple's maneuver is treatment of BPPV. Okay, BPPV, beta. Okay. Once again, beta. The Dick-Solpike maneuver is a diagnostic test of BPPV. Appley's maneuver is a treatment of BPPV beta. Dix-Solpike maneuver has got 2 positions. Appley's maneuver has got 5 positions. So 2 image-based question beta. If they show this image of two situation, 2 images together, Dix-Solpike maneuver, which is a diagnostic test of BPPV. If they show you this image of 5 images together, sitting to sitting to sitting beta, sitting, lying down, head turn, body turn, again you get up. This is the Appley's maneuver. It's a treatment of BPPV. Don't forget, beta, Dix-Solpike is a diagnostic test of BPPV. 2 images. Appley's maneuver is a treatment of BPPV. 5 images. Okay. Now, next question, beta. Now, a patient of head injury has bluish discoloration over mastoid area. Bluish discoloration over mastoid area, beta. Okay. Now, what is the bluish discoloration look like? Please see on the screen. That's the bluish discoloration. Can you see? Now, this bluish discoloration on the mastoid is indicating that there is some fracture of the skull base. And this sign is called Battle sign, beta. For a general surgery question of trauma, beta, Battle sign is the bluish discoloration on the mastoid area. This is seen in skull base fracture, beta. It means there is some fracture inside the skull. Okay. Bluish discoloration on the mastoid is called Battle sign, B-A-T-T-L-E, Battle sign, and this is seen in skull base fracture. Okay. Now what happens is, I hope you know facial nerve passes through the temporal bone, and temporal bone is a part of the skull base. After 3 days of head injury, after 3 days of head injury, the facial nerve got paralyzed. Patient developed facial paralysis. What is the treatment plan for this patient? Okay. Now please see, it's a delayed onset facial palsy. Delayed onset. It is due to edema. It is due to edema. After fracture, you can have 2 types of facial palsy. Immediate onset or delayed onset, beta. Immediate onset is due to fracture cutting the facial nerve. So that would need immediate surgery, beta. But in this situation, the facial palsy has happened after 3 days. This is delayed onset. Facial nerve has not been cut. There has been edema of the facial nerve which has developed in last 3 days, and that edema has led to delayed onset facial palsy. So what you give for edema is oral steroids, beta. Answer is oral steroid, beta. Let's quickly revise once again, beta. In the fracture of the temporal bone or skull, you can get the facial palsy. Yes. Now this facial palsy can be immediate or delayed. Delayed is due to edema. Immediate needs immediate surgery. Immediate needs immediate surgery, and delayed needs steroids. Delayed needs steroid. Immediate onset need immediate surgery, and delayed onset need steroid. Okay, bache, will you remember it? This patient is suffering from delayed onset facial. After 3 days is delayed, na? There is edema, na? For edema, you don't do surgery, beta. You just give steroid, beta. Okay. So once again, in the fracture of the skull, you can get facial palsy of 2 types. Immediate onset, need immediate surgery. After 3 days, it is a delayed onset facial palsy, which is due to edema, and that needs steroid, beta. Okay. Now look at the question again, beta. Now look at the question again. After 3 days, patient develop facial palsy. So 3 days after 3 days, delayed onset. Okay, it's delayed onset, and that's due to edema, and that needs the oral steroid. Treatment is oral steroid. Immediate onset facial palsy after fracture need immediate surgery. Delayed onset need steroids. Okay, very good. Now the next question. What is Bill's bar? Now Bill's bar, look at it. This is your internal auditory canal towards the skull, towards the brain side. And if you remember in your notes also we written that this is the vertical bony septum in the internal auditory canal, also called as internal auditory meatus. Okay, what is this cut, beta? What is this diagram drawn? This is this is internal auditory canal, also called as internal auditory meatus. So Bill's bar, it's a vertical bony septum in the internal auditory meatus. It's a vertical bony septum in the internal auditory meatus, beta. Internal auditory meatus is other name of internal auditory canal. You see on the screen, this is the cut section of your internal auditory canal, also called as internal auditory meatus, which is towards the brain, internal towards the brain side. Now, this is called a horizontal separator. In the upper part, you have a septum, vertical bony septum, and that is called Bill's bar. So, Bill's bar is a vertical bony septum in the internal auditory meatus. Bill's bar is a vertical bony septum in the internal auditory meatus. Am I clear, beta? Fine. Now, the next question. Now, this is a very popular question again. Mohan, 22-year-old male, gives history of right-sided ear discharge, foul smelling, blood stained. Very good. Now can you pick up foul smelling, blood stained? Now this is a case of unsafe CSOM. You know, unsafe CSOM means it can lead to complication. Now what happens is, this has been going on for last 6 years, but for last 3 days, patient developed fever with chills, headache, and pitting edema or mastoid. Pitting edema or mastoid. You know, pitting edema or mastoid is actually called Gressinger sign. Pitting edema or mastoid called Gressinger sign. I repeat, pitting edema or mastoid is called Gressinger sign, and Gressinger sign is seen in a case of sigmoid sinus thrombosis. Sigmoid sinus thrombosis. Once again, the answer of this question is aticoantral CSOM with the sigmoid sinus thrombosis. Once again, read it. Now, the background of patient is blood-stained, foul-smelling ear discharge. So basically, it's a case of unsafe CSOM, and it has been going on for last 6 years. But for last 3 days, there's a complication now. The main thing is fever, yes, fever, but pitting edema over mastoid. We know pitting edema over mastoid is called what? Gressinger sign. This is what Gressinger sign. Never forget, pitting edema on mastoid is Gressinger sign. Okay, and this is the feature of sigmoid sinus thrombosis. Okay, it is also called as lateral sinus thrombosis. One and same thing. Sigmoid sinus thrombosis or lateral sinus thrombosis. Nobody will forget. Pitting edema over mastoid is a typical sign called Gressinger sign, and the diagnosis is very clear. The sigmoid sinus thrombosis, also called as lateral sinus thrombosis. Why? Because sigmoid sinus is also called as lateral sinus. Am I clear? Fine. Now, next question. Next question. What is cupula in inner ear? The cupula in inner ear is gelatinous layer around crista. What is cupula in inner ear? It is gelatinous layer around crista. Gelatinous layer around crista. So cupula is the gelatinous layer around crista. D is the answer. D is the answer. D. The answer is D. D. Gelatinous layer around crista. Okay. If you remember, your inner ear. If you remember, this is your inner ear. This is your cochlea. This is your utricle saccule and semicircular canal. Okay. I hope you remember. This is your cochlea, saccule, utricle, semicircular canal. And semicircular canal have got what? Crista. Crista. And crista is covered by a gelatinous layer called cupula. Cupula. C-U-P-U-L-A. Semicircular canal have got sensory end organ called crista. And crista is covered by cupula. Now this is what? Utricle. S1 is saccule. Okay, utricle and saccule have got macula. Macula. Utricle and saccule have got macula. Like canals have got sensory end organ as crista. Utricle saccule have got sensory end organ called macula. Now macula is covered by a gelatinous layer which has got calcium carbonate crystals. Okay, and those crystals are called otoconia or otolith. Very important topic, otoconia or otolith. Once again, I repeat, semicircular canal have got crista, which is the sensory end organ of the semicircular canal. It is surrounded by a gelatinous layer called cupula. But utricle saccule have got sensory end organ called macula, which has got calcium carbonate crystals called otoconia or otolith. Now, for your kind information, semicircular canal control angular balance. Beta. Let's revise. Beta. There are three angles. Na? They control which angle? They control what? Angular balance. Beta. Okay. And but utricle saccule, these two, utricle and saccule, they control linear balance. Beta. They actually control linear balance. Beta. Okay, bache, fine. They control linear balance. Beta. Okay, because they have got otoconia and otolith. That is why in some of the books, utricle plus saccule are also called as otolithic organs. Otolithic organs, beta. Otolithic organs. Once again, let's revise, beta. Guys, inner ear is very important topic for, some terminology based question. Once again, beta, let's revise. First of all, come here, beta. Semicircular canal. What is the function of canal? Angular balance, first of all. What is the name of sensory end organ? Is crista. Okay, crista. Crista is covered by gelatinous layer called cupula. Beta. Now, next is utricle and saccule. What is the function of utricle saccule? Linear balance. Beta. Now, utricle saccule, the sensory end organ is called macula. And the macula has got calcium carbonate crystals called otoconia or otolith. That is why utricle plus saccule is also called as otolithic organ. Beta. Utricle plus saccule is also called as otolithic organs. Otolithic organs. Okay, fine. Now, so answer of this question, come back. What is the answer of the question? What is cupula in inner ear? The cupula in inner ear is gelatinous layer around crista. What is the cupula in inner ear? Is gelatinous layer around crista. Beta. Okay, so cupula is gelatinous layer around crista. Beta. What is crista? Crista is the sensory end organ of semicircular canals. Beta. Okay, fine. Sure. Now, which membrane separates scala vestibuli and scala media? This is actually cochlea. Beta. Now, please see, cochlea has got three compartments: scala vestibuli, scala media, scala tympani. Beta. So, which membrane separates scala vestibuli and scala media? The answer is Reisner membrane. Beta. Reisner's membrane. The answer is Reisner membrane. Beta. Reisner membrane separates scala vestibuli and scala media. Beta. Which membrane separates scala media and scala tympani? Basilar membrane. Okay. Now, what lies on basilar membrane is organ of Corti. Organ of Corti. Beta. Okay. Organ of Corti are covered by another membrane, and that is called as tectorial membrane. Okay, beta, fine. Once again, beta, cochlea has got three compartments: scala vestibuli, scala media, scala tympani. Scala vestibuli and scala media are separated by Reisner membrane, but scala media and scala tympani are separated by basilar membrane. Organ of Corti are lying on basilar membrane, and they are covered by tectorial membrane. Beta. Once again, scala vestibuli and scala media are separated by Reisner membrane. Scala media and scala tympani are separated by basilar membrane. Organ of Corti are lying on basilar membrane. Organ of Corti are covered by tectorial membrane. Tectorial membrane. Can you see what the other membrane? Tectorial membrane. Okay, now 55. Sorry, 55. Beta. One of the following is a feature of Meniere's disease. Beta. Meniere's disease. Beta. The answer is diplecusis. Beta. Diplecusis means patient hear better in noisy area. Beta. Okay. Let's revise all the cues. Beta. Presbycusis is age-related hearing loss. Age-related hearing loss is called presbycusis. Paracusis willisii is a feature of otosclerosis. Paracusis willisii is a feature of otosclerosis, means paracusis willisii means patient hears better in noisy area. Beta. Okay. Now, diplecusis is seen in Meniere's disease. Diplecusis means patient hears same sound in two frequencies. And hyperacusis, patient is getting very intolerant to loud sound. Beta. And that is actually feature of Bell's palsy. Beta. Bell's palsy. Okay. Once again, let's revise. Beta. Presbyacusis means age-related hearing loss. Paracusis willisii means patient hears better in noisy area. It is a feature of otosclerosis. Diploacusis means patient hears same sound in two frequencies. It's a feature of Meniere's disease. Hyperacusis is seen in Bell's palsy, means patient gets intolerance to loud sound. Okay. Once again, presbyacusis, age-related hearing loss. Paracusis Willisii, otosclerosis. Diploacusis, Meniere's. Hyperacusis, Bell's palsy. Once again, beta, presbyacusis, age-related hearing loss. Paracusis Willisii, otosclerosis. Then diploacusis, Meniere's, and hyperacusis, Bell's palsy. Okay. Now, next one, beta. 56. Interpret the audiogram given in the image and comment on the most probable diagnosis. Oh, okay. Now please see, if you remember, otosclerosis, otosclerosis has got Carhart's notch. Carhart's notch. This is dip at 2000 hertz in BC. Dip at 2000 hertz in bone conduction curve, beta. Dip at 2000 hertz in bone conduction curve, beta. Now look at the audiogram, beta. Look at the audiogram. This is the audiogram, beta. The upper line, if you remember the class, beta, discussion, the upper line is always the bone conduction, beta. Okay, bone conduction. And can you see at 2000 hertz, there's a dip. The line goes down, beta. This dip is called Carhart's notch, beta. This dip is called Carhart's notch. Carhart's notch, beta. So what is Carhart's notch? It's a dip at 2000 hertz in bone conduction. It's a feature of otosclerosis, beta. So the answer of this question is otosclerosis. My dear friends, the answer to this question is otosclerosis, beta. Once again, beta, the Carhart's notch is seen in otosclerosis. It's a dip at 2000 hertz in bone conduction curve. It's a dip at 2000 hertz in bone conduction curve, beta. So answer of this question is otosclerosis, beta. Otos, very easy, beta. Just see the first line, the upper line is always of bone conduction, beta. So this is bone conduction, and dip at 2000, dip, the hearing line goes down. Dip at 2000 hertz is called Carhart's notch, beta. Carhart's notch, beta. Everybody, do you remember Carhart's notch, beta? Please see. This is the Carhart's notch. Can you see, beta? At the 2000 hertz, you see there's a dip over there, beta. Okay. Guys, do you remember noise-induced hearing loss? You have a dip at 4000 hertz, beta. Don't forget, beta. There's another dip at 4000 hertz. Is a feature in both AC, BC, both. This is a feature of noise-induced hearing loss, beta. Please see over here, beta. Everybody look at the screen, beta. Please see. This is your 4000 hertz, beta. Can you see the line go down? Dip, and the lines go down, but the lines dip. Okay. So dip at 4000 hertz is seen in noise-induced hearing loss. And this dip is called acoustic dip. Once again, beta, dip at 2000 hertz in bone conduction is called Carhart's notch. And that is notch is seen in otosclerosis. But dip at 4000 hertz in air conduction, bone conduction is called acoustic dip. And this is seen in noise-induced hearing loss. This is seen in noise-induced hearing loss, beta. Okay, fine, bache, fine. Now, once again, beta, if you want, this is important. This is very important, beta. Carhart's notch is dip at 2000 hertz. It is seen in otosclerosis. But acoustic dip is dip at 4000 hertz. It is seen in noise-induced hearing loss. Never forget these two dips, beta. Okay. Now, the next question, beta. Otoliths, again, beta, we just did that. Otolith are also called as otoconia. Remember, they are found in which part of the inner ear, beta? They are found in the utricle and saccule. Okay, utricle and saccule. And utricle saccule are concerned with which function is linear balance, beta. Linear balance, beta. Okay, so otoliths or otoconia are concerned with which function of inner ear? Linear balance, beta. If you remember, utricle plus saccule is also called as otolithic organs, beta. Otolithic organ. And if you remember, utricle and saccule control which type of balance? Linear balance, beta. Once again, beta, see on the screen, beta. We have done this inner ear diagram, and you have done the this one. Beta. Please see. This was what we're talking about, beta. Please come over here, beta. Just come over star, beta. Utricle saccule. What is the function of utricle saccule? Linear balance, beta. Okay, they have got what? Macula. Macula contain calcium carbonate crystals, and that are called otoconia or otolith. That is why utricle and saccule is also called as otolithic organ. Beta. Otolith is a very important topic. Beta. Otolith. Beta. So otoliths are concerned with which function? That's the answer. Beta. That's the answer. Linear balance. Beta. Okay. Fine. Beta. So otoliths are part of utricle and saccule, and utricle saccule are concerned with which function? Linear balance. Beta. Linear balance. Beta. Everybody look at screen. Beta. Look at screen, and now please answer. Now please see. Otoliths are concerned with which function of inner ear? The answer is linear balance. Beta. Linear balance. Linear balance. Okay. So please don't forget this question. This is one liner which can still come. The otolith is a very favorite topic for the exam. Beta. Okay. Fine. Now the next question. Beta. Yes, this is a practical question now. 35-year-old lady, while cleaning her ear with a hairpin, accidentally damaged her eardrum. Can you see a traumatic perforation, beta? Can you see this lady has developed a perforation? She has just injured her tympanic membrane with the hairpin actually. So this is a traumatic perforation of the eardrum. What is the ideal management, the best management for such perforation? Shall you give some ear drops to the patient? Shall you do some surgery, or shall you leave it like this for some time? The answer of this question is conservative management. Please understand the very likely question. The answer is conservative management. Conservative management. C is the answer. Conservative management. Again, read, beta. 35-year-old lady, while cleaning her eardrum with a hairpin, accidentally damaged her eardrum. What is the best management of traumatic ear perforation? The answer to this question is conservative management. Conservative management. Conservative management. Conservative management. Okay, fine, beta. Okay, fine. Now, please see. Why conservative management? Because it can heal on its own. Beta. Don't try to put any eardrop. Eardrop is strictly prohibited. Don't do urgent laryngoplasty. Let the nature, within 3 months, it may heal on its own. Don't do any mastectomy for this patient. Beta. Okay. So treatment of traumatic ear perforation is actually conservative treatment, because the perforation may heal on its own. So if you get a question, what is the best treatment for traumatic ear perforation? The answer is conservative management, because the perforation can heal on its own in many, many cases. Okay. So there's no need of putting eardrop. There's no need of doing immediate laryngoplasty in this patient. What is the name of prosthesis given in the picture, beta, which is used in the treatment of serous otitis media, beta? Serous otitis media is also called glue ear, beta. Glue ear. Hai na, beta? Glue ear. And G for glue. Glue needs grommet. G-R-O-M-M-E-T, beta. Glue needs grommet. Glue needs grommet, beta. Okay. Glue needs grommet. G-R-O-M-M-E-T. Grommet. Glue needs grommet. Glue ear needs grommet. Glue needs grommet, beta. Beta. Glue grommet. Okay. Beta. So answer of this question is grommet, beta. Never forget, serous otitis media is the other name of glue ear, and for glue ear we put a prosthesis called grommet. Glue, G for glue. Glue needs grommet, beta. Okay. So this is actually a ring-like thing, and what it is grommet. G-R-O-M-M-E-T. Please do remember glue, G for glue ear, and G for grommet, beta. Glue ear needs grommet, beta. Okay, fine, beta. Now, so this is grommet, beta. Okay, grommet. Don't forget this image, beta. Grommet, can you see? Grommet is actually dumbbell-like, beta. The one side is inside the middle ear, na? But actual shape is like this, beta. Okay, grommet, beta. Okay. Now, next question, beta. 75-year-old diabetic patient. I told you, old diabetic. Ear question. 75-year-old diabetic patient present with severe pain in the ear, facial palsy. Examination reveals granulation tissue in the external canal. The answer of this question is malignant otitis externa. Never forget, old diabetic ear question, definitely answer is malignant otitis externa. Young diabetic nose question, mucormycosis. Old diabetic ear question is malignant otitis externa. Very risky infection. Very, very life-threatening infection. That's why somebody used the word malignant. It's not cancer, it's a life-threatening infection. So 75-year-old diabetic patient presenting with severe pain in the ear and facial palsy, and examination reveals granulation tissue in the external canal. What is the possible diagnosis? The answer is malignant otitis externa. Am I clear, beta? Fine. Next one. Next question is, yes. Treatment of choice in a case of otosclerosis but with positive Schwartz sign. when the Schwartz sign is positive, beta. Guys, otherwise the treatment is surgery. But when the MCQ says positive Schwartz sign is seen in early stage of disease. Schwartz sign indicates it is early stage of disease, and in early stage of disease, treatment of choice will be sodium fluoride, NaF. NaF. The treatment of choice will be NaF beta. Okay, guys, let me tell you, treatment of choice of otosclerosis. Everybody, treatment of choice of otosclerosis is surgery. The first one, surgery. The treatment of choice of otosclerosis will be surgery, like stapedectomy, stapedectomy. But if the MCQ says that treatment of choice of otosclerosis, but with positive Schwartz sign indicates early stage of disease, and in early stage of disease, the treatment of choice is sodium fluoride beta. Let me repeat, there are two questions of otosclerosis management. In general, treatment of otosclerosis is surgery called stapedectomy or stapedectomy. But treatment of choice of otosclerosis with the Schwartz sign positive, like this question, Schwartz sign positive is seen in early stage of disease, and the treatment of choice in that case is sodium fluoride therapy. Don't forget, beta, Schwartz sign indicate early stage of disease of otosclerosis. So in that case, you only give sodium fluoride therapy. Okay, now, next question, beta. Which of the following would be the most appropriate treatment for hearing rehabilitation of a patient with neurofibromatosis type 2 with bilateral vestibular schwannoma? Okay, please understand, neurofibromatosis type 2 is characterized by bilateral vestibular schwannoma. If you remember notes, beta, vestibular schwannoma is actually the other name of acoustic neuroma. Acoustic neuroma is which nerve tumor? Eighth nerve tumor. Eighth nerve tumor. Both sides, beta. Bilateral, na? Bilateral eighth nerve tumor. Please see, eighth nerve gone. Both sides gone, beta. Patient develop eighth nerve tumor of the right side and left side because patient is suffering from neurofibromatosis type 2. Neurofibromatosis type 2 has typical finding called bilateral vestibular schwannoma, also called as bilateral acoustic neuroma, which is actually eighth nerve tumor. So eighth nerve is abnormal in this patient. This patient is deaf. Now, can you go for cochlear implant in this case? No. Why? Because cochlear implant, the indication is bilateral profound SNHL. But what is the precondition of cochlear implant surgery? Normal eighth nerve. Remember, what is the precondition of cochlear implant surgery? Normal eighth nerve. In this particular question, both eighth nerve are abnormal due to tumor. So in this case, you cannot go for cochlear implant, unilateral or bilateral. In this case, you will have to go for brain stem implant. If eighth nerve is not working, you have to go to the brain to put an implant, beta, because eighth nerve is not working. So you have to put any electrical implant will be after eighth nerve. And what is after eighth nerve is brain, na? So you will give brain stem implant, beta. But beta, let me make your life easy. If the most relevant indication of brain stem implant is neurofibromatosis type 2. If you don't want to confuse yourself too much, neurofibromatosis type 2, which has got actually characteristic feature of bilateral vestibular schwannoma, which is actually eighth nerve tumor. In that case, we put a special implant called brain stem implant. Okay, brain stem implant. So what is the one indication you would like to remember about neurofibromatosis type 2? The answer is the brainstem. What is the one indication of brainstem implant would you keep in mind? The answer is neurofibromatosis type 2. Would you remember, beta? Neurofibromatosis type 2 has got bilateral vestibular schwannoma. Okay. So what is one indication of brainstem implant? You must remember neurofibromatosis type 2 or bilateral vestibular schwannoma. What is the one indication of brainstem implant? Would you remember neurofibromatosis type 2, or you can say bilateral vestibular schwannoma, because neurofibromatosis type 2 is characterized by the presence of bilateral vestibular schwannoma. Okay, now everybody, 63rd question. Which tuning fork is specifically used to diagnose otosclerosis? Please do remember one line question, Gillies test. Gillies test, please do remember, Gillies test is particularly used to diagnose otosclerosis. Gillies test is particularly used to diagnose otosclerosis. Gillies test is particularly used to diagnose otosclerosis. Otosclerosis. Okay, fine, wonderful. Okay, now next one. Look at the question number 64. A 43-year-old male patient is suffering from recurrent episodic disease of vertigo, hearing loss, and tinnitus for last 3 years. Beta. Vertigo, hearing loss, tinnitus, three feature beta. And disease is episodic. And episode has nausea, vomiting with vertigo. The episode settles in few hours only. What is the possible diagnosis? The answer is Meniere's disease, beta. Guys, try to recall. Meniere is episodic disease. Look at the screen, beta. Meniere is the answer, beta. Meniere is episodic disease. Number one feature, beta. Episode. Okay. Meniere episode has three features. Number one, tinnitus. Number two, vertigo with nausea, vomiting. Number three, hearing loss. And remember, Meniere's episode finishes within 24 hours, beta. So all features are supportive of Meniere's. Once again, beta, what are features suggesting Meniere's over here? Meniere is episodic, yes. Meniere episode has three features: vertigo, hearing loss, tinnitus. And Meniere episode finishes within 24 hours, beta. So vertigo, hearing loss, tinnitus. Episodic is the main thing, beta. And episodic disease is Meniere's, beta. You remember, there is one disease of vertigo which is episodic, is Meniere's, beta. Meniere's, okay? And Meniere's episode has three features: tinnitus, vertigo, hearing loss. Tinnitus, vertigo, hearing loss. And Meniere's episode finishes within 24 hours. Okay, now 65. Pulsatile tinnitus with bleeding polypoidal red mass in the external auditory canal of a female patient is typically seen. I hope you remember that famous question that a female patient with something pulsating or bleeding in the ear is glomus jugulare. Glomus jugulare, beta. Female patient, but please see, female patient with the pulsatile tinnitus, MCQ, beta. Pulsatile tinnitus in a female patient, 100% answer is glomus jugulare, beta. There is no other possibility, beta. Female patient with pulsatile tinnitus in an MCQ, the answer is glomus jugulare, beta. Once again, to remember, a female patient with something pulsating or bleeding in the ear is glomus jugulare question, beta. Okay, so pulsatile tinnitus with bleeding polypoidal red mass in the external auditory canal is actually glomus jugulare, beta. Don't forget, beta, a female patient with something pulsating or bleeding in the ear is glomus jugulare. Please do remember, pulsatile tinnitus is actually very, very commonly linked word with glomus jugulare, beta. And glomus jugulare is more common in females, beta. It's a very vascular tumor, and a very vascular tumor. So anything pulsating or bleeding in the ear of a female patient, the diagnosis is glomus jugulare. I hope you remember, it's a red vascular tumor. So you see rising sun sign. Very famous question. Rising sun sign is a feature of glomus jugulare. So glomus jugulare, very famous question is the rising sun sign, beta. But do remember, any female patient with something pulsating or bleeding in the ear is actually the glomus jugulare, beta. Okay. Now, 66 question. Again, a very, very commonly asked clinical scenario. 30-year-old lady has bilateral hearing loss. The keyword is bilateral hearing loss since 4 years, which worsened during pregnancy. Oh, I think we discussed in the class also, which worsened during a lady has hearing loss. It worsens during pregnancy. It's otosclerosis. Guys, you remember, otosclerosis is more common in young female. Okay, 30-year-old female. Then it's a bilateral disease. Okay. Then third is it worsens during pregnancy. Third, 3 points to call it otosclerosis, beta. It worsens during pregnancy. 30-year young female, otosclerosis is a bilateral disease and it worsens during pregnancy. And what is the audiometry, impedance audiometry curve seen is AS curve, beta. AS curve. AS curve, beta. Okay. So guys, please understand this is a typical scenario of otosclerosis, beta. Otosclerosis. This is a typical scenario of otosclerosis. Why? It is more common in young female, beta. 30-year-old lady. It is mostly bilateral and it worsens during pregnancy. That's the main thing. And what is the type of impedance audiometry curve is AS curve, beta. AS curve, beta. AS curve is seen in otosclerosis, beta. I hope you remember B curve is a flat curve. This one, beta. B curve, flat curve is seen in glue ear, beta. Please do remember these two curves, beta. AS curve is seen in otosclerosis, and B curve, the flat curve, is seen in glue here, beta. Am I clear, beta? AS curve is seen in otosclerosis, B mane flat curve is seen in glue here, beta. This is a typical case of otosclerosis. A lady hearing loss turning worse during pregnancy is otosclerosis question, beta. And the impedance audiometry curve is AS curve, but B flat curve is seen in glue here, beta. All are otoxic drugs except pharma question, beta. Chloroquine, yes. Amikacin, aminoglycoside, yes. Furosemide, yes. Methotrexate, no. Methotrexate is not the otoxic drug, beta. Okay? Okay, beta. The main thing is aminoglycosides, beta. The amikacin, the streptomycin, the gentamicin, and aminoglycosides. Okay? Which diuretic? Furosemide. Which antimalarial? Chloroquine. Quinine. Okay? And then NSAIDs, beta. NSAIDs, particularly aspirin, brufen, and indomethacin. Remember notes, beta. NSAIDs, aspirin, ibuprofen, indomethacin. Okay. Answer is methotrexate. Methotrexate is not otoxic drug, beta. Okay. Fine. Please do revise otoxic drugs. Okay. The main thing is the aminoglycosides, then furosemide and diuretic, chloroquine in antimalarial, aspirin, brufen, indomethacin in NSAIDs. And remember, anti-cancer, not methotrexate. Anti-cancer means cisplatin, carboplatin. Cisplatin, carboplatin. Cisplatin mainly. Cisplatin, not methotrexate, beta. Okay. Now, 68 question, beta. Which muscle is responsible for opening of eustachian tube during swallowing? Is a very famous anatomy question, beta. The answer is tensor palati, beta. And please do remember, tensor palati is also called as tensor villi palatini muscle, beta. Okay, tensor palati is also called as tensor villi palatini muscle, beta. Tensor palati is also called as tensor villi palatini muscle. Don't forget this, beta, please. This muscle, please don't forget, beta. Tensor palati and tensor villi palatini is one and the same thing. And this muscle is responsible for opening the eustachian tube during swallowing, beta. This muscle is responsible for opening the eustachian tube during swallowing. Once again, speak with me, beta. Which muscle opens the eustachian tube during swallowing? Speak up, beta. Tensor palati or tensor villi palatini muscle, beta. Okay. Now, a patient of head injury suffered tympanic membrane perforation with ossicular dislocation. There's a hole in the tympanic membrane. Along with that, the ossicle got dislocated, and how much conductive hearing loss is expected? 38 decibel. 38 decibel. Okay, guys, 38 decibel. Guys, let's revise. Wax can cause 30 decibel hearing loss. Okay, but glue ear can cause 10 to 40 decibel hearing loss. Am I clear? Wax can cause 30 decibel hearing loss. Glue ear can cause 10 to 40 decibel hearing loss. Beta. Then, please understand. Then there are two things to remember, beta. One is ossicular dislocation. Two possibility with normal TM, tympanic membrane, TM and tympanic membrane, with perforated tympanic membrane. So there may be a perforation also, but there may be normal tympanic membrane, normal. Now, in this case, you will get more hearing loss, 54 decibel. In this case, you'll get less hearing loss, 38 decibel. You know why? Because some sound energy will directly enter the middle ear through this perforation. Okay, so ossicular dislocation with the normal tympanic membrane, 54 decibel. Ossicular dislocation with perforated tympanic membrane, 38 decibel. Okay, once again, let's revise. Wax can cause 30 decibel hearing loss. Glue ear can give rise to 10 to 40 decibel hearing loss. Ossicular dislocation can have two questions. With the normal tympanic membrane, it will give 54 decibel hearing loss. With perforated tympanic membrane, 38 decibel hearing loss. Better. Okay, fine. So in this question, he's saying that the person is actually having the tympanic membrane perforation with the ossicular dislocation. Basically, there is a hole also, beta. So hearing loss is 38 decibel, beta. 38 decibel. Am I clear, beta? 38 decibel. So the answer to this question is 38 decibel. Okay, fine. Okay, beta. But ossicular dislocation with a normal tympanic membrane, 54, beta. I repeat, VEX 30, glue ear 10 to 40, ossicular dislocation with a normal tympanic membrane, 54, ossicular dislocation with perforation tympanic membrane, 38, beta. So this question is perforation wala na, 38, beta. And now the last question, beta. A child is born with this deformity of pinna shown in the image. Can you see, beta? There is no anti-helix, beta. Can you see, beta? Normal pinna has two curvatures, beta. Normal pinna has two curvature. One is helix, other is anti-helix. You remember there are two C, beta. One is helix, other is anti. Outer curvature is called helix, inner is called anti-helix. But in this case, if you see, the patient is not having any anti-helix, beta. Anti-helix is absent, beta. And this deformity is called bat ear, beta. So patient is born with deformed pinna as shown in the image. What is the name of deformity? The name of deformity is bat ear. What is bat ear, beta? The bat ear means absent anti-helix. Absent anti-helix. Outer curvature is helix, inner is anti-helix. Every pinna has two curvature. Outer curvature is helix and inner is anti-helix. Anti-helix. Am I clear, beta? Fine. So what is bat ear? Absence of anti-helix is called bat ear. And what is the ideal age of surgery of this patient is 6 years, beta. MCQ. When would you do the plastic reconstruction of pinna in this patient? The answer is 6 years, beta. Once again, what is bat ear? The bat ear is absence of anti-helix, beta. What is bat ear? The absence of anti-helix, beta. Am I clear, beta? Absence of anti-helix, beta. Okay. And let's revise, beta. What is that? What is the ideal age of surgery of bat ear is 6 years, beta. Now, number 2, cauliflower ear is other name of boxer ear, beta. Boxer ear. Boxer ear is the post-traumatic deformity of pinna. Cauliflower ear or boxer ear is the post-traumatic deformity of pinna, beta. Okay. And then the third one is tropical ear. It is actually the other name of diffuse otitis externa. Diffuse otitis externa. Tropical ear, which is also called as swimmer ear. It is other name of diffuse otitis externa. Due to moisture of swimming and tropical climate, there is a lot of infection of the skin of the external canal, and that is called tropical ear or swimmer ear, and that's the other name of diffuse otitis externa. And lastly, surfer ear is other name of exosteosis. Exosteosis. Exosteosis means extra bone formation. There's a hyperplasia of the bony external auditory canal. It is more common in water sports person like surfers. You know, surfing is sea sport, and the sea water goes in the ear and irritates your external auditory canal, and the bone gets hyperplastic. Look at the name of the exosteosis, meaning extra bone formation. Surfer ear is exosteosis. It is actually the hyperplasia of the bony EAC. Why it is called surfer ear? Surfer ear because it is more common in water sports persons, and surfing is a sea sport, beta. Okay. Once again, beta, bat ear means absence of anti-helix. Cauliflower ear means boxer ear, means post-traumatic deformity of pinna. Tropical ear also called as swimmer ear, its other name of diffuse otitis externa. And lastly, surfer ear is exosteosis. It is the hyperplasia of the bony EAC. It is more common in water sports person like surfing, and that's why it's called surfer's ear. Surfer's ear, beta. I'm a clear surfer's ear, beta. Okay. So this is bat ear, beta. Okay. This is the bat ear, beta. Okay. This is the bat ear, beta. Okay. So guys, this is the end of the this session in which I wanted to talk to you about certain revisions, and I will just say that all the best wishes for all of you, and I'm sure you would really do your best of revision in the remaining times, and you will really be your best version in the remaining days, and you would try to do as much revision of the content as possible. And if you have still any query, you're most welcome to mail me at this email ID, drrajivdhawan@gmail.com. If you have any question about anything, you can mail me at this ID, Okay, I'm at the Telegram also with my name Rajiv Dhawan ENT Educator. Okay, you can post the query there too on the Telegram. You can just search over there ENT. Okay, I hope this session adds value to your preparation. It was a lengthy session. It was supposed to cover salient feature of the topic in a systematic way, so that you are able to look at the topic in a clinical manner. That's what the purpose of the whole all these 70 questions chosen one by one. And I hope you will revise this video once again before your exam sometime, so that you're again brushed up with all the important concepts of ENT. And just watch the video again one more time with a lot of focus, hear all the concepts, so that you're able to crack the clinical question better. Okay, but the last thing I'll say before I leave this session and close the session is that please make sure that you are the best version of yours in the remaining days, because this will be the deciding part of the whole journey. Because the last part of the preparatory time, whatever data you see is more fresh, and is there a high chance that you will be able to recall that thing in the exam. And believe me, that's a way to go about it. And may God bless you hard work. You have been doing a tremendous hard work in all these months. Actually, I would say, I know there could have been much better thing we could have done. I know there are certain lacuna which everyone has. I have multiple lacuna, I must accept it, but at least we have tried to do our level best. And now in the remaining days or weeks, we will be doing the best revision possible. Beta, let's try to see as much content as possible. Let's not keep on thinking about negative, what will happen, only one thing beta, मैं अपना best करने जा रहा हूँ, बाकी जो होगा देखा जाएगा beta. This is the best what I like beta. And this is not that it's not innate within me, it's not inborn within me, but believe me, I have practiced to learn it like that beta. अपना best करेंगे, बाकी जो होगा देखा जाएगा beta, है ना? Thank you very much. God bless you all. And do take care. Please do revise this video once again before your exam with a lot of focus. Okay, that will be revising a lot of ENT for the question's sake at least. Okay, any question you have, you can email me at drrajeevdhawanent@gmail.com if you're on Telegram. And then you can just send me, it's my name only, Rajiv Dhawan ENT Educator. You can find out, just join that, and you can post there too if you have any query. All the best, beta. Do well. Thank you very much, beta. Bye bye.